să-i dăm drumul, că deja suntem late. Bună dimineața tuturor, good morning everyone. Deja suntem într-o mică întârziere and because we're running late, we have to catch up today. I don't know how we're going to do it, but we're trying to. Vă poftez cu mare drag, dacă mai e cineva afară, e rugat să vină să-și ocupe locul. Pornim încet, încet, vă salutăm, fiți bineveniți la cea de-a doua zi de conferință. Mulțumesc fetele de la Translation Booth care sunt pregătite să acopere tot. Mulțumim băieții de la tehnic care asigură transmisia. Am aflat că vom avea întrebări care vin de la oamenii care n-au putut să ne fie alături. Așadar vom avea întrebări venite din social media pe care undeva mai târziu la una dintre sesiuni le vom adresa și încercăm să răspundem la fiecare. Puteți folosi, e toată lumea confortabilă cu căștile,
Is everyone comfortable enough with the headsets,
simultană în limba română, limba
with the
engleză.
simultaneous
Mulțumesc mult.
interpreting? Okay,
Vă mulțumesc foarte frumos. Încă o dată scuze de întârziere. Diminețile pornesc un pic mai greu. Și pentru că nu vreau să iau deloc nimic din timpul dumneavoastră, spun bună dimineața invitațiilor pe care avem deja on the chairs. Și de asemenea, avem două filmări pe care le-am primit de la parteneri pe care vă invit să le vedem, după care dăm drumul primei sesiuni a dimineții.
And then we'll start the first session of the morning.
Dragă Mihăiță, stimați participanți la Dragă Mihăiță, stimați participanți.
Dear Mihăiță, dear guests at the conference, I'm sorry I can't be there with you in person. However, I assure you that today, as well as every single day, I'm there with you to support your fight. It might not seem so, but we, those who animate the Romanian health system, regardless of our position, whether we are physicians, officials, or members of patient associations, we are in fact there with you, fighting against the same common enemy, which is the disease. This is something we need to remind ourselves constantly in order to channel our energy effectively, to identify solutions, by keeping our hearts and minds open. I know that many of you have done this, and I would like to thank you for that. Today I want to convey this message to congratulate an old friend. He's very young. I would like to congratulate him on what he's doing for this health system. Instead of being reserved and reluctant, he is a mobilizer for the reduction of gaps in CF care for all patients in Romania. This cause hasn't been helped, but it has been repressed for over 40 years. So we're still looking for the potential to cooperate between citizens and the state. So we need to welcome all the endeavors of the patient associations, to ask the Romanian state to rise to the level of European standards. Dear Mihăiță, you have become a resilience role model before resilience became an EU concept. You are an integrity vector, although you didn't set out to do this, I think. And all this because you believe that this is the right thing to do. And this is a rare thing, and I welcome it. And I think we should promote this within the community of CF patients and as a role model for your whole generations too. I don't want to sing you praises with this presentation, although it seems like it. And it would only be fair to do so. However, what I do want to say is that there are people in the health system. They are there for you. People who admire you for the way you fight and who will stand with you. The first are for sure your physicians, your curing physicians. Ladies and gentlemen, your efforts, your open discussions, the perseverance with which you asked for support have brought this topic to the fore. Today, you have so many other players in the public and private sector who stand with you. Officials from the government, medical producers, physicians, and so on and so forth. I'm a counselor for the president on health issues, and I believe that this is the solution in the long run. I know this is an unequal fight and struggle, and it's difficult to find the inner strength to fight this fight. However, your contribution, the contribution of those of you who face the reality of this disease every day is irreplaceable. Nobody can tell your story better than you, and I urge you to always fight for your cause, and I would like to tell you that I will always support the improvement of CF care. The best of luck to you.
Bună ziua! Bună ziua întregului auditoriu!
Hello, ladies and gentlemen. Thank you very much for inviting me. I will send you a message on behalf of the physicians at the ambulance service. We all know that cystic fibrosis is a severe genetic disease that affects the digestive system and the lungs. It is caused by a genetic mutation that leads to sticky and thick secretions that can block the respiratory ways and other parts of the organism. The role of the emergency system in CF is essential, is crucial. I'm referring to physicians who work in emergency services because these physicians need to manage the acute complications that may arise in patients with this severe condition. Up next, I will talk about a few important aspects of the role of physicians who work in emergency services. The management of acute respiratory issues, these are under the limelight. CF patients may have respiratory exacerbations that need swift interventions in order to prevent severe respiratory insufficiency. Physicians who work in emergency services need to quickly evaluate the respiratory function and administer oxygen, bronchodilators, and IV antibiotics if needs be. It is also very important in the case of this condition to manage lung infections. These are very frequent in CF patients and in a very short time, may become very severe. A very quick diagnosis and starting the right antibiotic treatment are crucial to reducing the risk of lung function deterioration. Also, it is important to treat intestinal obstructions. CF may provoke such obstructions. The physicians who work in emergency services need to be able to identify the symptoms and start the treatment immediately. We cannot neglect the support we need to give for non-respiratory complications. The patients may have other complications such as diabetes associated to CF or liver failure. They might need emergency interventions. Assessing liver sufficiency is very important as well in CF patients. This is a disease that cannot be treated by just anyone or by just one category of specialists. We need to coordinate all the specialized teams that are needed. Physicians who work in emergency services need to collaborate closely with teams of CF specialists in order to ensure a continuity of care. The transfer of a CF patient towards specialized units might be necessary for complex treatments or in order to monitor the situation in the long run. It's important that this transfer of the patient be done in safety conditions and in the shortest time possible when the situation arises. Towards specialized unities, unities specialized in treating CF. In this kind of condition, we also need to educate the patient and the family of the patient. In emergency situations, it's important for the physicians to offer emotional support and information to the patients and to their families. The disease is severe, as I was saying, and it has a great emotional impact on the patient and on the patient's family. This is why communication between the medical personnel and the family and the patient is very important. The next of kin and the patient need to be taught the signs, the warning signs, and the necessary measures to be taken in order to prevent complications and acute crisis. All these measures may help to reduce the frequency of visits to emergency units. In conclusion, the physicians who work in emergency services have a vital role in the management of acute complications of cystic fibrosis. They need to be prepared to have a swift reaction and an effective reaction in order to stabilize the patients and in order to offer them the best possible care. Thank you. Thank you for inviting me to send this message. I regret the fact that I can't be with you in person for this conference. And I wish you a fruitful conference in the best conditions. Hopefully at the end of the conference you'll be able to draw the necessary and useful conclusions concerning the evolution of treatment in cystic fibrosis. And hopefully you'll be able to find the right measures for the patients so that the patients may be given the best of care in the shortest time possible. Thank you.
Mulțumim frumos. Trecem la primul
Thank you very
panel.
much. We'll move on now to the
Aș vrea
first
să
panel.
mulțumesc și să spun bună dimineața domnului profesor dr. Milan Macek și profesor dr. Elke de Wachter, care vor fi alături de noi pe scenă pe toată durata primului panel. La final vor avea partea lor de feedback, de adăugări, de completări, după care trecem la sesiunea de întrebări și răspunsuri. Începem așadar panelul cu diagnoza, Diagnosis of CF, pornim cu tema The Sweat Test as the essential part of CF diagnosis and newborn screening și invităm pe Lutz Nerlich, ECFS Patients Registry pentru prima parte a acestei conferințe. Mulțumim frumos, good morning and welcome.
Good morning, thank you for the invitation. I think for you as a parents, I think with patients with CF, I think, or children with CF, diagnostic has been a solved problem, I think. But I think we heard yesterday a lot about newborn screening, about the care, about the new chances, I think, with new therapies that will come up, I think, for them. So diagnostic is really essential to pave the road to care and to cure, I think. And I think from my heart, I think it's very essential to mention that this is really the key, I think, and the basic. It's a once in a lifetime. It has to be done very properly. Otherwise, you are misleading on the way, I think, and might not get the full access. These are the latest guidelines, I think, from the US, but also international groups, I think, from 2017. And it's clear that the clinical presentation of CF is, in the absence of newborn screening, there are symptoms and signs. We talked about that. That's malnutrition, that's chronic cough, chronic pneumonia, but all the other salt loss. But in the time of newborn screening, I think this is a biomarker, I think, in the blood, which raises suspicion to be checked for CF, I think. So it's a very healthy-looking child sometimes, where you have some suspicion and you have to sort out that question to really not fall into too much anxiety or other things, I think, bad feelings about that disease. And the key, I think, after 60 years and after 30 years of genotyping and genetic analysis is the sweat chloride, I think, is the sweat testing, I think. This is, I think, agreed all over the world, I think. And why is it? Because it's the only method where you can quickly do, I think, a test which makes CF unlikely on the right side. And this is very important, especially in newborn screening, where you have not always a diagnosis. It's a screening positive, but you have to confirm or to exclude or make unlikely the diagnosis. And the sweat chloride stays there quite over the 60 years, and it has to be done properly to take that role and to take that specificity and sensitivity. And then based on that, I think you can diagnose CF without genotyping. You would like to confirm it, I think, by the mutations because of the treatment options, but I think a sweat test is enough also to make the diagnostic of CF in the absence of genetic analytics. So that's a very quick and very challenging thing, which is also very important. And then you have the middle part, which is not so often, I think, the case, but I think in some cases, but the genetic analytics is very crucial. And I think you always know that we will hear about it. Not always the key is there to answer the diagnostic question. Our knowledge has been improved over the last years, but there's a lot of things to do. Sweat testing is a very complex procedure. It starts with a stimulating of sweat, with a sampling of the sweat, with, I think, analyzing the sweat. And in the 60s, I think it was a great thing to have a localized sweat stimulation by Gibson Cook on the left side, which is an old machine, but I think it's still in place. I have seen it in Georgia and other countries, also in Poland in some centers. The Gibson Cook is still valid, but the equipment is not so well standardized and could not always bought very easily. And then you have a filter paper where you really collect the sweat. You have to dilute the sweat from the filter paper. You have to do it very properly, but you get very good results. It's still in the guidelines, but I think it's not easily accessible in some countries or replaceable with new machines sometimes. One company has made the market a little bit more broader worldwide. It's called Elitech. And they have provided a system, I think they called Macroduct. This is in the right side of the stimulation, I think. You see, it can be done in babies very properly, and I think it has a stimulation localized and then a sampling in a capillary tube. And then you can use the sweat itself without dilution, I think, to analyze either with a sweat check, the conductivity, the chloride. But there are other methods, I think, on the way. I think on the right side, I think you see a stimulation in a baby, but it's also an analytic tool. And the Sanosol mentioned yesterday is the same, I think. You can stimulate and you can measure on the same probe. These are faster methods to a certain extent, but I think has some limitations, which I will mention. But unfortunately, we are faced also with regulations, and especially the medical device market in the European Union has been changed dramatically during 2023, because every device has to be re-registered, and that means, I think, it has to undergo every check from now on, I think, and this makes it very, this was one of the arguments to cut down some of the products. This is a round GLDIS, the old Macroduct. So the new Macroduct Advance is a new one that is registered, but the old one, established in many centers over the years and still valid, I think, could not be supplied in the European Union from the next years. And also the SweatCheck, the easy one, I think, from Elitech has been, is not longer commercially available. So I think the market has changed. We don't know for Sanusol if the medical device regulation has been applied on, but I think might be changed in the future, I think. Yeah. Sweat test is challenging across Europe, but also worldwide, and this is a survey from the ECSF Diagnostic Networking Group, which Elke is the director at that time, or the lead. I think this is done a survey around Europe, but also other countries. And I think it's really, really the true. I think there is a considerable variance in approaches and interpretation of results. That is really challenging, but on the other side, it is also, I think, raised some concerns. Many centers are not using the international agreed cutoff levels, so they can judge them differently based on a mix-up of information, so it's very important to focus on the main messages here. And we have a variance with respect to collect from two sides. And one issue, I think, it's a common goal, it's a cost. I think the cost is often not reimbursed. I think a pilocarpine iontophoresis with pilocarpine and so on costs around €5, but some of these devices, they have been developed and they cost €40 per measurement, and then you have also the labor costs, I think, for the people who do the test. So at the end, it has been calculated in the US up to $200 one sweat test, and I think this is quite the balance, I think, between no reimbursement but cost and labor intensive. And I think this is very important, I think, to balance it. And we always take that risk on us because we think it's so crucial for the diagnosis. It's a one-time shot, and then the path to very expensive medications might be open or not, or you can really send someone home as CF unlikely, which is often a more important message after newborn screening, I think. So the costs is a one-time cost, but I think it's a very well-spent money, I think. That quality matters is a message nobody wants to show, but even Harry Schwachmann in the beginning says he gets 58 patients to his center with a positive sweat test, but he could not confirm it in nearly half of the patients, because this variability leads to disclassification or misclassification, and sometimes this is conflicting for the parents to see that there are different results. One of the gurus, I would say, is Lee Lecrie, I think, from Chapel Hill. She wrote the most exciting publications and guidelines, but I think she reported also that they have in Chapel Hill, one of the most recommended centers in the US, I think, they have a false negative analytic of 12% in the 80s. And they have a diagnostic delay of more than 10 years due to the misclassification. And they have severe misclassification and consequences like surgery and lobectomy. This open-minded publication paves the road, I think, to really say quality matters for these patients, I think, even in a high economic system and quite in a very excellent CF center. In Germany, I think we looked also on the misdiagnosis in 2013, 51 patients, and it's mainly the sweat test which makes the misclassification because these were patients, I think, and then they could be excluded. I think they can be withdrawn the diagnosis sometimes because it was not well done or well interpreted. These are the international guidelines, and I think it's clear that the pilocarpine iontophoresis is a stimulation of choice, that the Gibson-Cook or the Macroduct system is a medium of collection, that the collection time should not exceed 30 minutes because of evaporation problems. But what is really crucial that you stimulate the sweat glands as much as possible, so a supramaximal stimulation, and that should require and be reflected in the minimum volume you get over time. And this has to do with the collection area and the sampling time. And this is 15 microliter for the Macroduct, But for the filter paper, you need much more, and this has to do something with, can you analyze 15 milliliter of a raw sweat? Not always in the lab. You dilute it, and then more problems come in. The chloride has been set up as a method of analytics, but we know that conductivity, as in the SANOSOL system, is quite a very good screening outread the conductivity, but needs also confirmation, I think, of the diagnosis with chloride or with genotype. And there are many other things. The interpretation of the sweat test is very crucial, I think, and we heard from the survey that there are a mismatch, and this is done because chloride is often mixed up with conductivity, I think. And this means, I think, if you have a sweat chloride, you have to realize that because here the cutoffs are 30 and 60. But if you know conductivity in general, it's 20 micromole higher. So the cutoffs shift to 50 and 80. And I think it's a good test, but you have to confirm it, I think, either by genoanalytics with confirmation of 2CF causing mutations or a real chloride measurement. And these are very good guidelines, I think, who takes also all your concerns in countries into account who are not so well equipped. And I think I like the paper very much because it really keeps the balance between what is acceptable and what is, I think, possible. What are the reasons of a false negative or positive one? Fortunately, if you do it properly, it's a very small number of patients. You have a high sensitivity, you have a high specificity. And if you look at the reasons for false positive and negative, technical issues are one of the major things. Yeah? If you don't do it properly, you can get wrong. Nutritional status, severe malnutrition, comes with a slightly elevated sweat chloride. But if the malnutrition is corrected, then I think you can remeasure. So it has to do also in anorexia. Edema plays a role, dehydration. Skin conditions like atopic dermatitis. But it's really, really rare that you can't imagine the other endocrinology reasons. But there are some mutations where the sweat test is normal or in the borderline range. And this is especially true for splicing mutations and some of the mutations mentioned here. The paper gives a good reference. I think it's freely available online. In time of newborn screening, I think you have to step one step back. These are clinically sometimes healthy babies presented to you. The parents are not convinced that there is a disease, and you make a test and you change the whole life of the family. So I think it's really an academic measurement and a readout. If it's done properly, it's robust enough, I think, to stand this and to justify these messages. You can do it as early as possible, I think, from the second, third day on. So you don't have to wait, I think. But one of the challenges is in baby, they do not sweat sometimes as much as an adult, I think. Even the surface for the testing is the same. You get also the problem, the quantity is not sufficient to analyze a probe. And this is really a challenge across the world. And even, I think it needs a very rigorous approach. And we mentioned yesterday, I think we heard from the Bucharest, from Marie Curie, I think meconium ileus, this leads to normal newborn screening. There's 20% of these patients where the inflammation in the pancreas have nearly stopped at time of birth, and the IRT, which reflects the inflammation, is going to normal level, and you have a false negative screening. So in meconium ileus, you always go for the sweat test. I think that's very important, not look at the newborn screening at all. I think if it's positive, yes, but if it's negative, don't ignore that signal and that chance. We heard about the late diagnosis yesterday. Be precise as possible, and I will mention that. You have CF unlikely. That means maybe, but you also have, I think, intermediate sweat tests or at that stage, and a new term comes up. The quantity not sufficient is related, I think. The expectations in the high-quality papers is in children who are older than 3 months, you should get a sufficient sweat probe and do the analytics in 95% of everyone. So But in children less than 3 months, it could be slightly higher, up to 10%. That means what do you do with that patient or this is parents? Do you send them home and say, come back? Yes, I think in general, you should do it not too long ago. Let's say 5 to 7 days you can do it and repeat it because you have an urgent question. Is it CF, I think? And the reasons for that, and this is mentioned in the column with the unsuccessful sweat call, are very young children, preterm babies, weight on test below 2 kilograms, you fail in 80%, but you have to get the right timing for the testing. CF spit, I think, is a consequence and a condition after newborn screening where you have a screening positive, but you can't make the final diagnosis. And this means you have an asymptomatic infant, that's very essential, with a positive newborn screening, and you have done a sweat test. And you have come up with a sweat borderline between 30 and 59, then you would definitely go to genotyping. And if you have 1 or 2 or 0 CF causing variants, I think it doesn't matter. It's still, I think, CF screening positive inconclusive type. If you skip the sweat test and you go directly for genotyping, you will come up with these other types where you have 2 CF variants and you don't know about that with a clear answer. And this makes it much more difficult. The prevalence depends on your strategy. In Germany, we go for a sweat test. We send the patients home with a sweat chloride below 30. So I think we reduce the genotyping in these cases where there is a borderline case, and we reduce the number, and this is really crucial. The prevalence, the conversion rate is very different from country to CF over life, and has been reported between 5 and 50%. It was a question, I think, from the workshop, I think, how is the follow-up? I think the follow-up is mainly the sweat chloride, I think, after 6 months, after 2 years, after 6 years, I think. Is there a change in the normal range? Is there an adaptation? There are some diagnostic tests, which are the extended genoanalytics, and the re-evaluation of the results over time. And last but not least, also the fecal elastase, which is very crucial. And then there is some care management. It's also freely available, that paper, I think, which gives a good and latest overview about it. In time of newborn screening, I think there are challenges, the preterm babies, but concentrate on the other 90% where you get the sweat test. Try as early as possible. First try one side, I think one arm, and if you fail, I will do it on the same day on the other side because I don't want to miss the possibility of a quantity not sufficient and to get the best results. You don't mix the volumes because in the American guidelines they do it bilateral, though the cost, the efforts are higher, so I don't agree on that in the time of the resources. If not successful, and this is very essential, if you don't get a quantity sufficient and you can't do a sweat test, you don't want to send a pancreatic insufficient patient home to fail and to get a malnutrition. So fecal elastase is the first step we are doing until we get the other sweat test appointment to really save the patients who have a fecal elastase who is too low, and then it should be rescued, because this is the first intervention, I think, in these patients. In conclusion, it's still the gold standard, and I think quality matters. I think high quality makes you really sure in the diagnosis, and conductivity as a screening method should be confirmed by genotyping or chloride. Don't mix up conductivity because this is totally misleading, and sweat testing for newborn screenings is an extremely critical step. You are major responsible, and I was really, I think, a little bit concerned about what we saw yesterday from Yash. 111 patients have a positive newborn screening, but there was only 5 or 6 who have a CF diagnosis. So you have to exclude it in 90% very probably, and this is a very critical question you have to ask yourself. So the high quality matters. And for modulator use, the sweat test is also useful sometimes with individual normalization, does not closely correlate with clinical response. Individual changes could help to identify some non-responders, so-called, or the compliance or medical reasons. I don't want to touch on that. But it's really critical. Sweat test is not old-fashioned, it's time-consuming, but it's less costs are than the genotyping, and it has to play a role. Milan knows me very well. I think I know in the past where the sweat test was not available, some go directly to genotyping, some countries. But that is, I think, something we should to avoid, and that's the reason why the ECS-FPR supports so much centers with the equipment, that you are in the position to do it, I think, properly based on the best you can do. Thanks.
Thank you kindly. Moving on to the next panel. Mergem mai departe cu următorul panel. O invităm pe doamna dr. Ioana Ciucă, vine tocmai de la Timișoara alături de noi.
We give the floor to Mrs. Ioana Ciucă, Dr. Ioana Ciucă from Timișoara, please.
If it's okay with you, you have this.
Thank you so much for inviting me. Regarding the topic of today, I want to add the fact that we still need to focus on diagnosis. Why do we speak here about the diagnosis, since most of you already are in therapy? But it is important to know what the weapons that we have at our disposal are, and maybe for some of you, the parents who had a late diagnosis, maybe to understand why this happened, and maybe you can at least share your experience with other parents. This is the disease of the 65 roses, although we know what the main issue is. Why do we speak about polymorphism? Polymorphism, just like the 65 roses, can include more than 65 symptoms and manifestations. If we speak about diagnosis, maybe you will say, yes, but we know what the disease is about, but how easy is it to diagnose it? This is a photo that showed on social media about a child coughing and having diabetes. With this image, most of you can know what this is about. But how about the doctors who are not familiarized with CF? And you'll see what's happening. What is a chronic cough? Maybe it's just a child who started kindergarten and just collects everything from his colleagues. But a chronic cough must be a warning if the children have bronchiolitis, pneumonia, and don't respond to treatment. And if the infections and all the other manifestations that you can see on the slide don't respond to treatment. They are cases at my colleagues that start with these manifestations.
The gastroenterologist should pay attention to things like pancreatic insufficiency. The pancreas might not secrete enough enzymes, recurrent pancreatitis, and for the liver disease associated to cystic fibrosis, which might not be clinically manifested. There might be a splenomegaly as well. And last but not least, a pathology related to the intestine. Some of you might have been, some of your children might have been diagnosed with a meconium ileus as well. There are distal obstructions when there is a lot of constipation in the children, and we need to go to the physician and let know the cystic fibrosis specialist. And there are also children who have inexplicable vomiting and recurrent abdominal pain. A mucoid appendix might also raise suspicion of CF. As for other conditions, and they wouldn't be the first patients who would be diagnosed through an associated diabetes. Male infertility, osteoarthropathy and arthritis and vasculitis might be manifestations of CF. The presence of clubbing in adults is not that frightening, but in children, it needs to take us to one type of severe condition. The existence of clubbing in children should raise suspicion of CF with family doctors as well. Most cases that escaped newborn screening can manifest through a growth deficit. A weight deficit, a growth deficit might be an indication. For small children, skin salty tasting might be a sign, and for adolescents, delayed puberty, and for adult ozoospermia may be general manifestations. We can draw up all sorts of tables and make all sorts of associations, but it's important to mind the age segments as well. Recognizing the disease in a patient that escaped newborn screening is important for newborn experts who should know that the presence of certain phenomena during that time in the newborn might be a warning signal. Gynecologists might also notice some sort of suspicious activity. Dilated bowels is an indirect sign and should constitute a very clear indication for a sweat test for the future patient. We need to thank all those who were involved in initiating newborn screening in Romania. And ever since we've had it, we can say that diagnosis is easier. But as you saw in the previous presentation, sometimes many cases escape newborn screening. So we also need to make the clinical assessment as well as go through all the diagnosis stages according to the European Society. More often than not, CF patients start off with the obstructions we were talking about yesterday that generate atelectases. When it comes to children, we also need to think about the presence of hyperproteic edemas, the presence of hemolytic anemia, as well as hypertonal dehydration, for instance, in a small child might suggest CF. Moving on to toddlers, recurring wheeze episodes that respond or don't respond to treatment is important for CF diagnosis and may represent an important sign. The existence of steatorrhea with that specific smell, the existence of nasal polyposis, and here the ENT specialist should be noticed, and most of our colleagues with the ENT specialty know that this pathology can be associated with CF as well. The existence of rectal prolapse. Pediatric surgeons should be let known about this, and they are noticed. Chronic abdominal pains are a sign. And last but not least, hypertrophy. As for adolescents, we have patients who were diagnosed when they were 16 who only had weight hypertrophy. The parents didn't find it weird that they had several stools a day. But when the delayed puberty was diagnosed, and when spirometry was carried out, or CT scan or radiography of specific phenomena, led to the suspicion of CF. What other signs do we have when it comes to age segments? Any physician that carries out a spirometry and realizes that there might be a fixed obstructive syndrome, if there's no bronchodilation and there's an obstructive syndrome, we should bear in mind CF. Because the fixed obstructive syndrome with negative bronchodilation is a major factor of CF. The existence of typical infections such as Pseudomonas or Staphylococcus can also be a factor that, for microbiologists, it should raise suspicions. Many microbiologists called us saying that, look, we found this Pseudomonas-resistant strain. So there are a lot of signs. We all know them really well. Also, radiologists who carry out radiologists or CT scans will know that the existence of bronchiectasis is highly suggestive of CF. In the pathology of the child, we don't carry out CT scans as often as with adults, but it's extremely important to detect these signs and to bear in mind the idea of CF. A gastroenterologist may see the presence of those stones, gallstones, that appear very rarely in the pathology of the children, but which are highly suggestive of potential CF. We insist on early diagnosis, and that is because it's very important to diagnose CF in its early stages. Let's see if it's as important as we think it is. Ever since the beginning, the first studies, and here I would like to underline the role of registries again, the European Registry of Cystic Fibrosis, in it, one of the first warning signs showed that the association of a low nutritional index may lead to a low lung function as well. This is one of the first studies that was published, which underlines this fact due to the information that the physicians reported about the patients. That's why it's really important to report all the patients with CF to the European Registry. We gave up reporting towards the Romanian registry because it's much more important to report the patients to the European Registry. As you can see, there are so many studies, and you will see up next as well, that show that a patient that has a chronic infection with Pseudomonas will have more exacerbations and will have a less favorable evolution as compared to those patients whose weight is normal or who don't have infections. The presence of exocrine liver insufficiency leads to a less favorable evolution as compared to patients who have a sufficiency in liver function. Decades ago, evidence suggested that though the patients who are diagnosed early through screening and who undergo therapy, who receive therapy but are also informed about the fact that they need to have an optimal nutritional status and need to avoid chronic infections, have had a clearly improved evolution. Patients with CF diagnosed early on clearly have a nutritional status that is something closely related to lung function. And we know that lung function is the one that dictates the evolution and the prognosis for the evolution of disease in such children. If there is malnutrition, we usually also have a lower pulmonary function. That's why nutrition intervention is essential. And I saw that we will have a lot of presentations on nutrition, which is very important. Knowing the risks of infection, what is important is to prevent a chronic infection, which is less probable. But it's very important when we know that we have a chronic patient we need to administer the right therapy. There is another study which has been recently published that shows that in patients that were monitored, chronic infection with Pseudomonas, diabetes and malnutrition are associated with lower lung function. This conclusion was possible due to the fact that the physicians reported all the cases to the European registry. It's important to have an early diagnosis because with the diagnosis we have therapy venues at our hand. Once we know the diagnosis, it's important not to give up on treatment. We need to continue with the treatment and we need to apply it correctly according to the international guidelines and standards. Even if we use new medication, it's important to continue with the aerosols, inhalations, and to go through physiotherapy. Sometimes we say, if a child is accustomed to all these therapies as a child, we might come across some kind of resistance as he grows older, but he will at least be used to the therapies. So please continue therapy, keep at it. If you have any questions or any unclarities, please always talk to the curing physician. We have all sorts of medications. Pulmozyme, I remember many tens of years ago, but now we know how important it is to associate nutritional solutions and liposoluble vitamins. There's so many other, there's a lot of medication in the pipeline that will potentially have even better results than the ones we're using today. In conclusion, I would like to say that the earlier the diagnosis, the better the chances of a patient having an improved life. The clinical signs are still important and we need to know them, even if we do have newborn screening in Romania as well. An early diagnosis will always allow for a correct nutritional and therapy care. This will lead to better lives and to longer lives for CF patients. This is not just a dream, but a clear definition. You might have heard of Chopin. At some point, people were saying it would have been so important to diagnose Chopin early on. He might have had cystic fibrosis. He had two sisters. One of them had a very similar pathology. He was described as a patient who was intolerant to fatty foods. Unfortunately, he died very early when he was just 39. He was suspected of tuberculosis at the time. So it's important to know all the necessary data. Maybe at the time it wouldn't have been important to have an early diagnosis for him, but now it's very important to diagnose all the potential little Chopins around us. Thank you very much for inviting me. This is our center, and don't forget that there is always a better hope for the future. Thank you.
Mulțumim frumos doamnei dr. Ioana Ciucă.
Thank you so much, Dr. Ciucă. And now I would like to invite Dr. Milan Macek, who comes directly from the Czech Republic.
Okay, good morning, everybody. Thank you for the invitation. And as I said, I've been talking many times in front of our Romanian colleagues, and I dare to say also friends. So let me just update you what's new in genetics and how genetics is important in the context of new therapies. I want to say that my life was made very easy by the two previous speakers, and but I mean, not the latest presentation was uploaded, I have to say. This is the old one, but never mind. So, yeah, it's the one with the final suffix. Can we? Okay, yeah, thank you. This is the one. So CF is a recessive syndrome like any other. You know, I'm a medical geneticist, and cystic fibrosis is a disease, a genetic disease like any other. We tend to, I would say, single it out for practical purposes because it fell initially in the domain of gastroenterologists. Later, it became a domain of pulmonologists, and now it's a domain of multi, I would say, specialty approach. You will hear about it in the afternoon. And it's caused by pathogenic variants, before we call them mutations, in the cystic fibrosis gene. And it's a recessive gene, which means that you need to have mutations or pathogenic variants on both chromosomes, which one comes from the mother, another one from the father. As you can see on the slide on the left-hand side, oops, it's not working. Anyway, you can see, so you have the classical form, non-classical forms, and I will refer to the previous talks which describe that. Now, we compile all the mutations in two databases. The original one is called CFTR1, or also the Toronto database, which now has over 2,400 variants, and they are spread, as you can see, all over the entire gene. It's a great effort. It still continues, but the downside is that you don't have proper clinical annotation. It's more or less like a locus-specific genetic database where researchers are entering unknown alleles, but nowadays we see less and less, I would say, inclusions, because most of the alleles are now put not into CFTR1, but into so-called ClinVar database, which is curated in the United States and which compiles variants from all the rare diseases, including rare cancers. So we are now trying to put these two databases together. Also, the 2024 Nobel Prize, which was announced 3 weeks ago, in fact spoke about the use of artificial intelligence. And I can tell you, and we are proud as a CF genetics community, that the AlphaFold, which is sort of modeling all the proteins in our body based on AI, and I would say shared protein characteristics, has a spin-off which is called AlphaMessense, and it's another database which is really high-tech, which essentially put all the missense variants, the changes of amino acids in all genes in our body, including CFTR, into one database, and looks at how the protein is sort of modulated structurally in 3D. I don't want to go much into detail, but you can see on my right-hand side, you can see the model which was just published two weeks ago in Nature. And in fact, when they compiled the mutations which we know about in the cystic fibrosis gene, vis-a-vis what was predicted by artificial intelligence, out of those 2,400 mutations, only 4 were misdiagnosed. So you can see the power of a joint genetic approach towards AI and how these are working together. And as you can see on the pie chart, missense mutations are still dominant in the gene, and they represent one of the major diagnostic challenges. But now with AI and with all these advanced bioinformatic algorithms, we can move forward very quickly. Also, as I said, CF is a syndrome like any other, and CFTR variants, or mutations, doesn't matter which term I will use, are in fact expressed in an organ-specific manner. It's not only in CF, all genetic diseases act that way because you have tissue-specific expression of proteins. So for instance, just very briefly, in the sweat gland, the sweat is, the chloride is pumped into, while in the lung, it's pumped outside. Right? So just this simple thing which people don't realize. But also you don't realize that CFTR protein and CFTR gene, it's an equivalent, don't act alone. So if you look on the genetic level, on the top of the pyramid, and Lutz spoke about it very well, if you look on the sweat gland, you know, CFTR protein and gene are the only ones responsible. And if you go, for instance, down to the pancreas, you already see that there are some modifier genes present, and I don't have much time to go into detail. And the more you go down the pyramid, the more yellowish or oranges it becomes. You not only see the CFTR gene, that's the blue dot, the big one, but also you see these small moons, you know, either they are orange or they are blue. And those are all the modifiers like mannose binding, lectin, growth factors, and so on and so forth. There's a lot of them, but so far clinically, it's nice science, but clinically it's very difficult to use them in clinical predictions on the course of the disease, and we still would need not only more research, but also better bioinformatic algorithms which can assess that. Also, you can see that there are certain, Lutz mentioned that meconium ileus. Meconium ileus is almost entirely genetic, while the distal intestinal obstruction syndrome is essentially a non-adherence expression of a dietary mistake. So, you know, genetics is not 100%, and we call it nurture versus nature. Nurture is, in our terms, in the CF domain, is how we treat and how the patient is adherent to therapy, how the family, secondhand smoke is treating the environment within which the disease is developing, while nature is in fact our biological genetic determination. Also, the CFTR activity and associated phenotypes, we can discuss this a day-long session, and it's always a very interesting subject. But suffice to say that there's a continuum between the percentage of wild-type function of the CFTR protein and what disease the affected individual has. So if you have less than 10%, and that's why also in clinical trials 10% change is a very important threshold, as I will show you later on. You have classical form of CF. If you have between, let's say, 10 roughly to 40-45%, you may have a CFTR-related disorder, but we don't have time to discuss this. And if you have above 50%, like in the CF carriers, in the CF parents who are obligate carriers, you have no disease. But even in CF carriers, it's not completely sure whether they don't have some other affections related to the CFTR protein. We can leave it to the discussion. Now, we also know that now we have 7 classes of CFTR mutations, while between class 2 and 4, the variant-specific therapy, which is also called CFTR modulating therapy, is effective. But we need to concentrate now, because, and it's also related to the presence of the F5-way del, which is the dominant allele. But it's not the whole story. The more we go to the southeastern Europe, and even if we go outside of Europe, like in Africa, Central Asia, and Southeast Asia, you realize that delta F508 or F5-way del is not the major mutation. The mutation heterogeneity greatly increases, and it's the same for Romania, as we will show later on, for Bulgaria, for Turkey, and so on. So the more you are southerner, the more highly variable your gene is, and the more mutations you have, and you need to look on the rare variants. So you need to sequence. You know, if you use, like you presented yesterday, 30, 34 mutations, you will miss all these rare variants. And as I will show you later on, you will also miss intragenic rearrangements, which you get by sequencing. And they are quite common as the CFTR delete 2-3 in Slavic populations. You will also miss major disruptions of the gene, structural variations, ALU repeats. I can talk about it for an hour, but just essentially you really need to sequence because the mutation architecture, as we call it in genetics, in the CF gene is quite complex, and essentially looking for the usual suspects for the common missense mutations or missense indel mutations is not the one. Modifiers, as I said, modifiers are quite interesting story. It all develops. Mainly now we see it develops in the field of diabetes, where many modulators are affected, and also in the innate immunity related to the lung disease. Now, what Lutz presented yesterday is the European registry. And the most common pathogenic variants in Europe are also present in Romania and are present in Southeastern Europe, but in much more, I would say, different frequencies than when you have the overall picture as in the registry. The other thing which changes dramatically the mutation composition of patients, but not only in Western Europe, which is mostly, I would say, affected, quote unquote, by increased immigration, non-European immigration, is the fact that we have more and more non-European immigration, not only in Western Europe, but also now in Central and Eastern Europe, Southeastern Europe notwithstanding. So if you look on these figures, for instance, if you look on the most common country of origin of foreign-born populations, so in the UK it's Indians, in Spain it's Moroccans, in France logically it's Algerians, and nowadays in Central and Eastern Europe, it's the Ukrainians. And we have a substantial Ukrainian immigration, not only into our country, to Germany, but if you look in the pre-war situation, the pre-2022 and the post-2022 immigration, the map shows the pre-2022 while the chart shows the post-2022 immigrations. We have a substantial amount of Ukrainian immigrants who flee the war or who flee dire economic situation, and we need to adjust our screening panels accordingly to this influx of people. We also now need to deal with non-European and Central, I would say, West Asian immigration or Middle Eastern immigration. We need to deal with consanguinity, and consanguinity is now becoming a major issue in genetics because we have like cystic fibrosis and thalassemia, sickle cell on top of each other, because essentially in the Middle East you don't find anybody with a sort of clean hemoglobin. So in the end, as I said, we've been involved in 2 Vertex charitable donation programs which ended in April 2024. We still have some leftover money, so we still accept samples. And thanks to Lutz, we will now start the ECFS-sponsored genotyping scheme on the same conditions as before. And moreover, we will be now able to offer you clear, I would say, structured clinical and laboratory reports, and probably you have seen it in your email, and I now speak to my Romanian and Slovak colleagues here in the room, asking you to help us identify the cases which were pseudonymized, send us the names and date of birth, and we will send you signed clinical reports which you can put into your files and use for eligibility for CFTR modulators. So we call the project Filling in the Gaps. I don't have time to go much into detail, but many publications came out of it. And we are in the process. As I said, it's an academic, non-binding, no strings attached collaboration where we try to help to have essentially not to leave anybody behind in terms of sequencing. We offer it as before based on testing of Guthrie-Carrs because they are very easy to be shipped, and we sequence the entire gene using the divisor assay, and we also look on 6 introns which are known to harbor majority of mutations. It's robust, user-friendly, and quite fast. We also detect quite common alleles in Southeast Asia and Southeast Europe and Central Asia, so essentially we look on the non-European regions. Here you can see that we can also detect large deletions, which are surprisingly common in our region. We can also detect huge deletions in the gene, duplications in the gene. So CFTR, like any other gene, is not static, it's quite dynamic gene, and through very advanced sequencing which we use, we can detect it. And also we can now detect so-called revertant alleles, alleles. If you have this complex allele on the same chromosome in the same gene called F508del and L467F, you know, these cases are not eligible for modulators because they change the steric composition of the gene and block the binding site of some of the modulators. And it's very important to detect those who don't respond to modulators and optimally before they are even instituted. We also closely work on the analysis, on the pathogenic analysis, not only using AI, but also using very good databases such as the CFTR2 and CFTR France, where you have a lot of these rare variants which we help you to classify. And in the end, we were able to detect 27 novel variants, mainly in Southeastern Europe and in the Middle East. So in the end, I will just quickly go through the neighboring countries here. So in Bulgaria, we were able to publish a complete Bulgarian overview, including the Bulgarian Turks, and it's published, it's in the public domain, together with Gergana Petrova from Sofia. We also collaborated and still collaborate with our Hungarian colleagues, and it's quite, I would say, relevant for Transylvanian populations, which are quite common. So it's all published. We also work, and I'm glad we have colleagues from Macedonia here. With Macedonians, we have very good overview now on the situation in Macedonia. We also have a limited number of patients from Moldova, and we still continue working with colleagues who followed upon a departure of Oksana Turciu. So Moldova, and again, that's relevant for the Iași region. And in Romania, again, thank you very, very much. And as I said, it's not only collaborations, we developed also friendships. We work with 5 centers, and we will be more than happy to get also cases from Constanța, and all the collaborators are listed here, and I hope we didn't misspell their names. So thank you again very much, and we are very happy to continue. And as you could see, we have now processed 268 cases, including some segregation analysis. So I would roughly say it's 40% of all the Romanian CF populations, and we will be happy to finish all who have one or no CF mutation identified. Serbia, we also work with the Serbians. Here, the collaboration is ongoing. With Slovaks, we also do our best, and I'm happy that we can continue our collaboration. And now, in terms of immigration, I have to say that we still have an ongoing excellent collaboration with Ukraine, mainly with Western Ukrainian centers, even pre-2022. And these data are very much useful to our German colleagues, Estonian colleagues, and hopefully also to Romania, because there's still a substantial immigration from mainly Western Ukraine into our countries. Okay, so in the end, as Lutz has said, you know, genetic testing is part of the diagnostic algorithm. We need to do genetic testing, and I would say we need to do sequencing. It's not only looking at the variants, it's looking on the intragenic context. As you can see, the variants have various, I would say, affiliation to various classes, so it's not only a single class within which they fall to, and it has a lot of impact on the response to the modulation therapy. The other thing is that I heard yesterday, and I added this slide for sure, is to show you that if you work with sequencing labs which are commercial and which are not specialized on CF, and it's not only for CF, we say that to any other rare disease, you really need a person and an analytical group which knows what they are looking at. Because if you apply the generic bioinformatic algorithms which are used for exome screening, which are used for genome screening, it's a one-size-fits-all approach, and they are not conclusive, and we tested that. So except for the alpha missense, which is now validated on CFTR, all the other bioinformatic algorithms are not very good because they are looking on loss of function or gain on function, and they don't assess the intermediate so-called variants of variable clinical consequence, which give us a lot of headache. That's why we need to still work closely, and we are glad for that, with CFTR2. You know all this, you know this database, and this is one of the typical examples of a variant of a variable clinical consequence, the D1152H, which pops up quite common in CF SPID, which we see quite common in neonatal screening, and I'm looking forward to the presentation later on during this session. And here in CFTR2, you can see the compiled data like the summary information, sweat chloride information, lung function, pancreatic insufficiency, and so on and so forth. So the more, together with you, we feed in the database in CFTR2, we globally increase the validity of interpretation of CFTR genotyping. This is how it looks like. Finally, we have a fantastic tool that we work together with the Hopkins group and with the people around the tissue cultures, which use the FRT cells, which is the fish red thyroid cells, and they were able now to characterize the in vitro modulator responsive for 655 alleles. And it's a very big step forward. This paper came out recently. It's in the public domain. So all the rare mutations which we now found, can be classified and can be assessed whether patient could be eligible for modulator therapy. And this is a big step forward, which we offer in our collaboration to you. It's not only the 177 or 75 now, sorry, I didn't get the right number, but it's 170 plus variants which are also used by the FDA in the United States. And beyond that, you have these 655 alleles, together with the so-called 7 alleles from the French Compassionate Program. So all of this can be put into our reports and help you and serve your patients to get a better diagnosis and also better starting point for variant-specific treatments. Thank you very much.
Mulțumim frumos, profesor Dr. Milan Maček.
Milan Maček. He has come all the way from Prague, the Czech Republic. We now invite Professor Ioana Streață, who will talk about genetic testing options in Romania for CF patients. Hello, everyone. Thank you for inviting me. Thank you for giving me the opportunity of being here with you. As Professor Maček was saying, the previous presentations have really made my life easier. And that is because I will particularly focus on what we can do at this point in Romania for our CF patients. Of course, when it comes to genetic testing, cystic fibrosis, as we have already seen, is a genetic pathology. It is one of the most frequent genetic pathologies, at least in this area and in our country. The cause is a genetic defect at the CFTR gene on chromosome 7. And I will continue by talking about the genetic diagnosis that we currently use in Romania. We have newborn screening for CF, which is a very good thing, because diagnosis can be made much earlier and interventions can be done on time. However, for genetic confirmation, things are a bit more difficult, and I will tell you why. Since 2022, we've had newborn screening for CF. When the screening is positive, the assessment should be continued from a multidisciplinary point of view and should be confirmed through the sweat test. And then, when a genetic confirmation is needed, the patient and the family of the patient should reach out to genetics. Why? We saw this in the first presentation today. If we don't have the same two variants present in the patient and we have two different variants in the CFTR gene, the question is this a variant does each variant come from each parent? Or are the two variants on the same page, so to speak? Ideally, in such situations, we should have a sort of trio sample to also have samples from the parents in order to be able to confirm a diagnosis. Once we've done the genetic testing, we should either go towards a custom-made and individual case management approach, or, which is equally important as the first, the registries. So we need to have both approaches, in fact. And when it comes to the registries, we're not very well organized. As for genetic testing, in order to genetically confirm a CF diagnosis, we can resort to several types of genetic testing. A new generation sequencing would be ideal, but we have seen that in over 45% of the cases, we might have a single notification, Delta F508. So we can use targeted testing, such as real-time PCR or MLPA, which are less costly and quicker. Plus, they're more easy to organize. They're more easily organized than NGS. For the time being, we have 7 regional centers for medical genetics in Romania. They're evenly distributed all throughout the country, and they try to cover the whole area of the country. In Timișoara, in Cluj, in Oradea, Iași, Târgu Mureș, București, and Craiova. These are the 7 regional genetics centers. Within each center, there is one medical genetic cabinet, and we have bed wards as well. What can these do for the patients who are suspicious of CF? In this table, I tried to put together information about the techniques of genetic testing in all the 7 centers, as well as genetic counseling. There is the capacity and the logistics, so there is the correct equipment within the network, the Romanian network, but the problem remains the funding for the actual testing. So we can do sequencing of up to 9 generations in our centers, but things go slowly with the funding bit. When it comes to genetic counseling, this is a genetic disease, so it is present in all the 7 centers. It is very important for a young couple, for instance, who has a CF child. It's very important for these parents to be able to get the child to one of these centers and understand what the probability is to have a second child with CF and see what the available options are. Here is all the contact data for all the 7 centers. When the CF diagnosis has been confirmed genetically, one of the 7 regional genetic centers can help with parent testing in a quicker and less expensive way. In Craiova, where I live, and I will present now the story I know best. So Craiova is a town in the southern part of Romania, and it hosts one of the 7 regional genetic centers. It was created in 2014. Initially, it was coordinated by the late Professor Mihai Ioannou. Thanks to him, we are one of the centers that have complete equipment for genetic testing. We can carry out all the genetic tests that are currently available in the market within our center. We also have the 3 main techniques that might be needed in diagnosing CF. MLPA, if we want real-time PCR, so we have real-time PCR, we have MLPA, capillary sequencing, which allows for targeting sequencing. And here we need to test all the carriers in the family. So it implies a collaboration with our colleagues in Holland helped us get all the reactives needed for this kind of testing. And next generation sequencing is also available when delta F508 is not detected, or real-time PCR with those very small panels of punctiform variants are negative. We can use next generation sequencing and do the sequencing of the whole CFTR gene. Here are a few images from our lab, so that you get an idea of the whole flow. We have the welcoming part, RNA extraction, real-time PCR, and the real-time PCR point. And if that is negative, we can move on to number 4, the sequencing part, either NGS or capillary sequencing. We are funding for genetic testing from 2 sources: the National Insurance House that pays for a newborn screening for frequent syndromes, and as for genetic sequencing and testing for heart diseases. The other testing we can do are supported through a national program by the Ministry of Health. It is called the pre- and postnatal prevention of congenital malformations. Within this national program, we managed to carry out testing for those cases that are suspected to have CF. We can cover the MLPA for delta F508 through the kit we have at our disposal for a bigger number of patients. But when it comes to a next generation sequencing, the funding we have at our disposal through this national program are not actually enough to cover all the needs. So, we believe that we need to come up with a common strategy with the colleagues who do the clinical management of patients with CF. So we all need to collaborate and request the necessary funds from the insurance house and the Ministry of Health. Now we have newborn screening. When this is positive, it needs to be genetically confirmed. And then we need to carry out family testing as well. Thank you.
Mulțumim frumos, doamnei dr. Ioana Streață. Continuăm cu doamna dr. Delia Corina Elena, Newborn Screening in Romania. Mulțumim foarte frumos. Sărbuna.
Biochimist, nu sunt medic. Da, nu știu.
I am not a doctor, as you introduced me. I'm just a chemist. I'm not a doctor, but thank you for the introduction.
Cu doamna dr. Justina Stan de la Institutul Național pentru Sănătatea Mamei și Copilului și, într-adevăr, o să fac referire în
Thank you for inviting me. I will have a short introduction about newborn screening in Romania. Okay, now that I figured out how to work the presentation, I want to say that we've been talking about the warning sign. We know that newborn screening was introduced in Romania not in 1970 like in other parts of the world, but in 2020. It was functional very quickly. The moment we introduced it in 2022, actually, in July 2022, and since July 2022, all children have this newborn screening. It's not a diagnosis test, it's just a screening process, and then other testings follow. We note that there are costs for the confirmation of the diagnosis. We have a methodology to do the screening, and you can see here the steps. I will insist a little bit on this slide, mentioning that more often than not, we can have some issues because the samples are not of a high quality, because sometimes there are contaminated samples, sometimes the quantity is not enough, and sometimes we have to ask for retesting if the samplings are not okay, and it can lead to false negative or false positive results. We have signaled previously these issues, but if we have a positive result and if we have the suspicion of CF, there is the protocol that you know to inform the public health department to ask for a retesting. And in this form, you need to mention the reason for which you ask for a new test. Then, after the second testing, I will insist on the fact that this test needs to be repeated because it is considered to be positive if the value is more than 70, but the observations of our lab are that the borderline is 60 to 70, and we noticed that even if the values exceed 50, we should recommend a new test, a retesting, so that we don't mix diagnose. It is extremely important to make sure that a negative result is indeed negative. We can't afford to make mistakes in these cases. I, for example, have at least 2 examples in our center of mixed diagnosis. So it's better to make sure, just to see if a false negative, we skip false negative. False positive results are still not good, and we don't have a good feedback, and it doesn't make us worry less. For Bucharest and other counties in yellow, you see that this is our lab. So our lab covers all the yellow regions in Romania on this map. If children are born in other regions far away from Bucharest, maybe they don't come back to be retested. If the parents live far away from Bucharest. So at some point we lose track of them. This is the division per hospitals, but we have 3 centers in Bucharest, Marie Curie, Grigore Alexandrescu, and another one. And if the other hospitals are in Bucharest, then it's easier to collaborate with them. We tested in 2023 almost 78,000 children. No, 72,000, I apologize. There is a poor communication with the National Insurance House. We had more than 100 refusals for testing. We also had a poor communication with this National Insurance House and with the Directorate for Public Health. Sometimes we send them the documents, and sometimes these forms are not forwarded to the parents. Sometimes they get lost by mail, which is of course not okay. Some of the samplings are lost by mail, and there are also other challenges with which make our lives worse. This was what I wanted to share with you. If you have any questions about the screenings, I will be happy to answer. But I want to underline the fact that newborn screening is extremely important, not just for CF, but it would be great to introduce extensive metabolic screening so that we can cover other diseases. Thank you so much. And before moving to the Q&A session, we want to ask our chairs to give us feedback, to add something, or to just move on to the Q&A as you wish.
I would like, in the first place, to thank all the speakers for their wonderful talks, for their very interesting topics, because everything stands or falls with a good diagnosis. And it's tremendously difficult for patients, for parents, to have a reverse diagnosis because the diagnosis was made with too few information. So that is something that we really need to keep into our minds. I would like to just to raise a question to the lady who gave the last talk. So I understood that the newborn screening program in Romania is an IRT measurement. Where is it very defined when you need to do your second IRT measurement? Could you comment on that, and what are the pitfalls? Because people have to go, I understood, to the same hospital, or can they go to another hospital nearby just to do a second Guthrie?
N-am înțeles întrebarea, îmi cer scuze.
Dacă pacienții trebuie să meargă la același spital sau pot să meargă și la... Can you repeat it again, please?
So, when the IRT is raised the first time, we need a second IRT, I think.
E nevoie de 2 testări?
Da.
Ok.
Automat.
Yeah. And at what time? Is the time really fixed, or is there a period where you
Și timp...
În 3 săptămâni. De la prima... În 3 săptămâni.
The retesting needs to be done in 3 weeks.
Because this time is quite important.
Yes.
Is there a possibility that if people live far away, that they can get their second IRT test in a center nearby, in a hospital nearby?
Nu mai are relevanță, trebuie direct testul sudorii, dar ar fi de...
Și în același loc, întreabă dacă în același spital...
Dacă este vorba de testare screening, da,
If we have a
la
screening,
noi.
it
Dacă
needs to
este
be done
vorba
at
de
the same
testul sudorii,
hospital.
către
If it's the
centrele alocate
sweat
în alte,
test, it can
alte
be
centre.
anywhere.
The same one for the second testing,
Da.
the sweat.
Da. Nu există centrele, tot la noi. La noi. Da, am spus că la noi. Nu, la noi. Am spus că la noi. În 3 săptămâni. În maternitate. Recoltarea în maternități.
We apologize, they are not using the microphone. Could someone signal the chairs that we do have interpretation? They couldn't use their headsets.
Maternitatea în care am născut, de cele mai multe ori, da.
So, even if they live remote from the hospital where the first determination was done, they have to be announced by the sanitary institution to go back to the birthplace and to have the second determination. So they don't have local centers where to go.
And so that was an introduction to my most important question. Do you have a lot of missing data then
Yes.
for the second IRT?
Aveți multe situații în care nu vă vine.
Nu foarte multe, dar există în jur de 150.
No, there are
așa,
not
cam
many
pe an.
situations like that. About
Un procent,
150
la
cases per
72.000,
year.
deci vreo 2.
So 150 cases to 72,000.
Thank you.
I don't know the percentage.
If you have any more comments, otherwise we have questions.
Am o întrebare referitoare la testarea genetică.
Regarding genetic testing, I want to ask about the Craiova lab. Can we do it even if we pay it, even if the parents pay for it? Is it possible to pay? For the moment, we only do free testing, free of charge, but we do want to introduce this part so that we can cover more cases. We want to have shared efforts with our colleagues from the pulmonary department, because we want to have more and more cases that can be covered by the National Insurance House. We also need to be competitive from their point of view. So at least if we don't have free of charge, so if we talk about NGS, right, we are talking about NGS. NGS needs to be provided free of charge or at least at an affordable price. for the parent. Unfortunately, we are still working on it. We want the NGS to be around 300 euros. That's our target. For the moment, we cannot provide it, not even if you pay it. I am curious, if I may, and this is a question for Dr. Macek. I have two children, two twins, non-identical twins, two little monsters who will turn 8. How should... I am surprised, to be honest. I'm very surprised that their disease is manifesting very differently. One of them had a lot of manifestations, colonizations. He doesn't gain weight. He's very frail. The other one, he didn't even have symptoms. We learned about the diagnosis only after the sweat test. And when his brother was diagnosed, then we also had him tested. And I'm curious, why such a difference?
This is quite a difficult question. It probably may not be related to the CFTR variants, mutation status in the CFTR gene. There could be some variants in the immune system, there could be some variants in the innate immunity, and so on and so forth. So it would need a more complex checkup, which is not only in genetics, that's what we do in these so-called discordant twins, but we do immunology, we do endocrinology, and so on, because that's most likely has to do with the essentially different genetic and clinical architecture in each of these discordant twins. So we can talk about it, and just wanted to ask, your both twins have the same mutations in the CF gene?
Da, amândoi au aceleași gene, delta
They have the same delta F508 and another one. 1667. One of them is more frail. That's all I can say. I don't have any other explanation.
We see it also in normal non-CF children, that they really do differ, and sometimes we don't know why, but we can talk in the break. And it's a boy and a girl, or two boys, two girls?
Sunt băieței.
Two boys.
Și cu atât mai mult în...
And I found it even more surprising that when my child Philip was detected with Pseudomonas when he was 1 year and a half, his brother Vladimir didn't even catch it.
The situation with the immune system which needs to be checked, because I assume that adherence and family care is the same. So.
Okay. Mulțumim, thank you.
Bună ziua. Voiam să vă întreb.
Hello, I wanted to ask you something. If the child was diagnosed with an extensive panel for CF, I was tested myself. Should the mother also be tested?
It depends why you do that. If in your child, assume your child has cystic fibrosis, if you found both alleles, you mean both the maternal and the paternal, usually if they are well known, we don't do testing of the parents. If you have rare alleles where we are not sure whether they are on both the paternal and maternal chromosome or whether they are on one of the chromosomes of the parents, which means that either they are in trans in genetic nomenclature or in cis, which means they're in the same gene, then we test the parents. So it depends on which mutations were found in your child and why testing of parents was indicated, and we can discuss it during the break.
Bun, mulțumim, thank you. Mai avem o întrebare?
De fapt, ar fi două întrebări. Bună ziua.
I have two questions. Hello, my name is Frâncu Adrian. I want to ask you if I am a carrier, I am healthy, my wife is also a carrier and is healthy, can we have another child? Is there a link between delta F508 and some liver diseases? Because I am a carrier of delta F508 and I suffer I have a sensitive liver.
I mean, to the first part of your questions, of course you can. There are various methods in genetics where we can offer you, as we now say, informed reproductive choice. That means that if you would like to avoid having a child with cystic fibrosis, you can either opt for the traditional prenatal diagnosis, which means that the baby is tested once it's conceived, or in the first trimester. But then it's potentially associated with selective termination of pregnancy in case of an affected fetus, or you can go via assisted reproduction into pre-implantation genetic testing when we select a so-called non-affected embryo for CF. Of course, we then can do also the common aneuploidies, chromosomes, and so on. And I know that in Romania this is possible, although it's not covered by as far as we know, by the healthcare system. So that's absolutely possible, no problem at all. For the liver disease, it depends what type of liver disease you have, but usually CF carrier status per default is not associated primarily with impaired liver function. As far as I don't know about any such clinical conditions which can be explained only by mutations in the CFTR gene.
Mulțumim, sper că v-a răspuns. Alte întrebări? Să răduna, vă rog, doamna doctor.
I just wanted to make a few comments. First of all, I would like to thank Professor Lutz-Nerlich, who helped us a lot. He helped a lot of centers with sweat tests. This way we can carry out the sweat test now. I'm glad that the European Society accepts the conductivity test because most of us do it with Macroduct. We carried out a study in our clinic on over 2,500 testing with Macroduct, and indeed under 50 there was no patient, but when the values increased to 50 or 54 we did have. They were liver sufficient. 75 was the most unambiguous value. A big value of the sweat test is correlated with the degree of liver insufficiency. The bigger the sweat test value, the bigger the insufficiency. There are patients who are who have liver sufficiency. They were diagnosed a bit later and the pulmonary disease evolved and their evolution is bad, in spite of the fact that the sweat test is just 60, so borderline. Secondly, I would like to thank Professor Maciek for having done a lot of the sequencing of patients in Romania. He helped us to know exactly what genetic mutations our patients have. So now we know if they're eligible or not for future therapies. And I'm thinking about those patients who are non-delta F508 in the future who will have treatments. We have a Sanasol device as well. The problem with Sanasol, which for me is a bit more delicate, is the fact that you can't see the sweat quantity. In order to have a correct sweat test, you need a certain amount of sweat. And using this method, you cannot see the amount of sweat. So you might get false positives or false results. Thirdly, last year, out of 5 new patients, 3 didn't have meconium ileus, but atrophy. So atrophy can also be involved in this diagnosis, jejunal atresia, in fact. There is a lot of work going into this disease, and there's a lot of international cooperation between Europe, the US, Canada, Australia. There are studies coming from all over the world, from all these countries. There are so many patients. We take the outcomes of these studies and we try to apply them on our patients. Professor Maciek tested the whole world, basically, so there's a tremendous effort behind this work. So please appreciate the fact that we're trying to help you, and we're trying to update the treatment here in Romania. As I've noticed in all the presentations we listened to, there is this common thread. Where there is a will, there is a way. We need to implement it in Romania as well. When we really want to do something, we really need to find a way. Our foreign guests demonstrated that CF Europe, including, works this way. Thank you.
Last question, ultima întrebare, am depășit destul de tare timpul. Știu că e o problematică de suflet, dar
everything else.
My
son has cystic fibrosis, and I wanted to ask, at birth, they collected stem cells from him. Have you encountered situations where collecting these stem cells at birth were beneficial in cystic fibrosis later?
Stem cells from the baby, you mean? Affected with CF?
Au recoltat celule stem de la bebeluș?
Yes. Stem cells can be used to make small organs, like they do with the intestinal stem cells taken for intestinal organoids, and that can help towards more individualized personal medicine. However, if you have the genotype, the CFTR genotype, and your son or your daughter is carrier of F5-way-DEL, I think it's more worthwhile to just follow the standards of care and start normal therapy like we normally expect to do if you find that mutation, instead of doing very high-tech scientific research on the stem cells. It might be that if your son or daughter doesn't respond to the medication that we expect them to respond to, then it might bring some additional information. But it's really something that that needs a lot of efforts and a lot of money to the examinations on the stem cells. So knowing something about CFTR gene is already a lot of information that we have and that we can plan further treatment.
I may just quickly add that we see that on behalf of the Genetic Society that these usually commercial offers for stem cell storage and so on are driven by the hemato-oncology group, where they are trying to get, I would say, a broad base for donors for stem cell transplantation and so on and so forth, bone marrow transplantation. In CF, it's not very useful, so it very much depends what you were offered, how you were counseled, and for what purpose these stem cells were collected. And I can tell you that sometimes the marketing of these various companies is not completely, I would say, accurate, to put it diplomatically. Yes.
Mulțumim foarte frumos, sper că va...
Thank you very much. Hopefully the answers were useful to you. We need to take a break now, but before that, I will ask Professor Ioana Streață and biochemist Corina Elena to come here on stage very quickly so that we can give them their certificates.
Professor Milan Maciek and Professor... Who else do we have? That's it? That's it. You had yesterday.
just one small comment. Because of the importance of the sweat test, we want to draw your attention that on Saturday we have a hands-on sweat test session, because sweat testing is very, very important. It gives you information on how the CFTR protein works. So that's a functional test. So don't forget Saturday afternoon sweat test hands-on session.
Ok.
Microduct Advance.
Super. Luăm cea mai scurtă pauză. Short.
We'll take a very brief break.
Profesor Dr. Elke de Wachter, imediat cum ne întoarcem, we'll see you in 10 minutes because we're kind of late. Îmi cer scuze, mergeți liniștiți la toaletă, luați o cafea și ne vedem în 10 minute. Ăsta e timpul. Mulțumesc frumos. Ne pregătim să începem, doamnelor, domnilor, stimați invitați, dear guests. We're getting ready for the next panel. Ne pregătim pentru sesiunea următoare. Vă rog să vă ocupați locurile, să vă pregătiți. Ok, vă poftesc, vă rog să vă ocupați locurile. Mulțumim frumos. You escape. You're doing good. It's perfect. Nothing happened. No, that's the model. It's okay. Don't worry about it. Okay. Watch out for that. Yes. Așadar, de la partea de diagnoză, a primului și diagnoză genetică a primului panel, trecem la care, standards of CF care, centralized CF care with CF teams. Și pentru asta invit pe scaunele de pe scenă Dr. Mike Bon, PhD, lecturer Laura Dracea, PhD și senior pediatric CF dietitian Chris Smith. Ei sunt cei
There are the three guests who will be here on stage. If everyone is ready, let's start. For our first panel, Standards of CF Care in Europe, we have Professor Elke de Wachter from Brussels, Belgium. Thank you.
Hi everyone. I think we must get started. I'm going to talk about standards of care in Europe. And what are standards of care? It is actually guidance for best practice in CF. It defines statements on all health-related issues in CF, taking into account an evidence-based framework, especially systematic reviews, and opinions of experts in CF field, opinions of people with CF, of the community, and an agreement on the ECFS board. And that is done by using a Delphi process, so giving different statements, and if there is agreement of more than 80%, this is included in the statements. So the aim of standards of care is establishing and maintaining health in a changing environment, aiming to increase life expectancy in people with CF, aiming to get a better quality of life of our patients. So recently we had an updated version of the Standards of Care for Europe, and this resulted actually in 5 different manuscripts, altogether comprising 40 pages. And these 40 pages, they have statements, and these are the different statements, and altogether we have 119 statements. And obviously I will not be able to go in depth in all these statements in a talk of 20 minutes. So I thought, let's first go back to basics. Let's see why all of this is needed, because that's the basis of going then further in depth. So as you all know, CF is an inherited disease. It's important that your patients and parents from patients understand what it is all about, because in normal circumstances, we have the gene, a unique code that gives information on how the protein, which starts as a chain, see it as a chain of pearls that has to have a certain length, And then this barcode gives the correct information on how the chain should be folded, should be trafficked, and should be inserted in the apical membrane of all the cells. And there it functions as an ion channel. So what happens in case CFTR is absent or CFTR is dysfunctional? There are two main things. There is an abnormal chloride and sodium transport, and this results into a depleted airway surface liquid. And secondly, there is also an abnormal bicarbonate transport, and this results into the sticky secretions. So let's have a deeper look. This is a nice overview of our airway cells. The red dot is the CFTR protein, and on top of this you see these hairy cells. You see the hairs. The hairs, we call them cilia. And we need these cilia to move all in the same direction so that we keep our lungs healthy, we keep them clean. These cilia move to get rid of all the secretions. And in order to have a normal activity of these cilia, the cilia need to move in a water layer that has a certain thickness. And the driving force for this water layer is optimal secretion of salt, and that is done by the CFTR protein. So in normal circumstances, these cilia can move all in the same direction, cleaning our airways. But in case there is absent or reduced function of the CFTR protein, we see that this water layer becomes very, very small, and that the cilia won't have the chance to work properly. And this results into an impaired mucociliary clearance. And what about these sticky mutations? If we look a little bit more depth in how a secretion, a mucin looks like, they have these typical cation shields, as you can see. This cation shield is a shield with positively charged ions. And in the presence of bicarbonate, these positive charged ions, they fold open, and it results in secretions that are less sticky. But in the absence of bicarbonate, this cation shield is remained, and that explains why we have sticky secretions. So with knowing all that, we see that there is an increased survival in people with CF, and that is thanks to a better understanding of this basic defect. It's also thanks to earlier diagnosis, as we heard from previous talks today. It's thanks to access to better, to more supportive therapy, for multidisciplinary approach, for the use of standards of care, and thanks to the new generation of drugs. What we need to target, definitely, is progressive lung damage. And in order to strive for better lungs, we need to understand what's really going on. And thanks to this gene mutation or pathological variant, we have a defective CFTR protein, and this results into this, and it really doesn't work, this abnormal ciliary clearance. This leads to obstruction, chronic inflammation, scarring, chronic bacterial infection, and then you enter into this vicious circle. So if we aim to increase life expectancy and better quality of life, we need to avoid getting deeper and deeper into this vicious circle, and we need to avoid irreversible lung injury. So three main things how to reach to that goal is to have a timely and accurate diagnosis, is to establish and maintain health with optimal CF care, and to have access to CFTR-modulated therapy. So first of all, a timely and an accurate diagnosis, one of the papers of the standards of care. A rapid and an accurate diagnosis means that you have earlier access to correct treatment. And newborn screening for CF has proven to be very important of having a better outcome. The sweat test as a diagnostic test obviously is very important. Again, a reminder, the sweat test working shop will be on Saturday. And next to a sweat test, we need a good sweat test for a diagnosis because it translates the function of your CFTR protein, but we also need CFTR analysis results. Why? In case of an inconclusive sweat test, but also in case of an abnormal sweat test, to know if this can guide us to further treatment options. There are some pitfalls in diagnosis, as you know. You can have false positives, false negatives. There are challenging cases like CF-SPID, CFTR-RD, all very interesting topics that I cannot highlight today because of lack of time, but this is a very, very interesting paper to read and easy to understand. What else in standards of care? Establishing and maintaining health. Respiratory outcomes, they relate best to survival, so best to an increased life expectancy, better quality of life, and a healthier life for people with CF. And what is key to this is achieving excellent nutritional status. We have heard this from previous speakers, and it is true. It's something that we really need to tackle. Maintaining airway health and engaging with exercise. Importantly, and this might be surprising to some people, but you need to know that the lungs are in continuous contact with the environment. So it's not only the genetic information that gives an effect on the respiratory outcome. There are environmental factors as well, like exposure to tobacco, like nutrition, like stress, but also the age of diagnosis, therapy adherence, that all have an impact on the respiratory outcome. So these are key, these are things that we, as healthcare providers, as families, as patients themselves, can work on. First of all, eating well towards an optimal growth is a very important topic. Optimal early growth has an important impact on respiratory outcomes, and that means that we need to give optimal dosage of pancreatic enzyme replacement therapy. Let's call it CREON. We call it CREON. It's much easier to pronounce. So if there is a patient who is pancreatic insufficient, they need to get access to CREON at every meal they take, especially if the meal contains proteins, fats, and complex carbohydrates. We need healthy food. We need calories, yes, but we don't want our patients to become obese. We want them to have a healthy weight and to have muscles. What else? We know that thanks to the abnormal working of CFTR, or the absence in the sweat gland, people with CF, they lose more salt than healthy people. There, the sweat test is based on that principle. But in case of excessive sweating, we need to realize that our patients might be depleted with salt, and in these cases, extra additional salt is needed. It can have an impact on growth if you chronically lack salt. And what else? Despite the good efficacy of CREON, we still have some problems with digestion, and it can happen that patients, despite an optimal taking of CREON, they lack the fat-soluble vitamins like A, D, E, and K. So that's about growth, but towards an optimal lung health, if we realize what is really going on in the lungs, we do understand that physiotherapy and airway clearance techniques are very important to get rid of all these obstructions. And what else? There is a communication with the upper airways and the lower airways. So keeping the upper airways healthy and clean can have a positive influence on the lungs. So it's nasal rinsing is easy, is cheap, is something that our patients should do every day. Clean air. It seems obvious, but we need to think of it. It's not only pollution, it's exposure to tobacco, it's exposure to vaping, not only the parents but also the patients, and there is a key of the team to educate families, patients about inhaling clear air. Being active. We know that patients with CF have an increased life expectancy, so we need to maintain their health, and therefore we need to promote physical activity. And then another thing, a very hot topic has always been adherence to therapy. Support from the CF team is needed for that with education. Why do I need to take this medication? And if you go through with your patients on what is the pathophysiology, what is the aim, what is the reason why I need to inhale hypertonic saline, pulmozyme, it is important that the patient knows why they need to take this medication. And shared decision-making might help in getting a better adherence of therapy. So we need to target also the lungs, of course. We need to target inflammation and infection because there the vicious circle starts. And what we really need to do is to recognize pulmonary exacerbations. Pulmonary exacerbations are intermittent clinical deteriorations in CF lung disease, and they are usually treated, they need to be treated with antibiotics orally or intravenously. And it can be seen as an acute clinical worsening, but can also be seen as an acute decline in lung function. And important to keep in mind is that up to 35% of people who exacerbate, they fail to recover to previous baseline lung function. So we really need to avoid pulmonary exacerbation. We really need to recognize it in a very early stage. And to do so, it's important to know what is the baseline. And that's the reason why it is so important to see your patients every 3 months, to find out what is the baseline lung function of my patient. It is important to take respiratory samples, to do a clinical assessment, and to measure height, weight. It's so important. So these 3 months visits are not only for respiratory samples, but it gives you so much more additional information. At the same time, you can educate on the role of mucoactive drugs, on the role of therapy adherence. If you find a Pseudomonas aeruginosa, it is important to eradicate. There is proof that it gives better outcomes. And if you fail to eradicate, then chronic suppression by inhaling antibiotics is still the way to go. But we know CF is not only the lungs. It's a multi-organ disease. And what we know also is that outcomes improve if there is a better control of the non-respiratory complications. So there is need for attention of these other organs, but also of mental health. If mental health is better, the body responds. Sometimes we need to choose our battles because it's a lot. If a patient has different complications, therapy adherence might be difficult. But then it is our task to choose our battles with the knowledge of the CF lung pathophysiology and to see what is the most important thing. And there I think we need to highlight good weight, good length, a good eating and support, and seeing what is doable for the patient. Obviously we can, this is actually the very first paper in this series, targeting the basic defect before the vicious circle. What does it mean? If we can target the blue box, then we can avoid getting into the vicious circle. And that is where variant-specific therapy or the CFTR modulators are all about. They try to repair the protein that is defected. There will be a topic highlighted. Mieke Boon will talk about these, so I'm not going too much into detail. But in a changing world, with access to CFTR modulated therapy, we all know that it's not for everyone. It's not everywhere accessible due to reimbursement and financial problems, but it's not for everyone either. It depends on age, it depends on your CFTR variant, it depends whether your system relies on FDA or EMA. So our CF multidisciplinary team has to see 2 groups of patients, those who are on modulators and those who are not, who will never be or are temporarily not on modulators. And do they have different needs? Yes, we think so. Do they need different treatment strategies, different follow-up? What about sputum samples in those who don't have sputum anymore? What we know is that they all have to be supported by the same team of healthcare providers. And probably different approaches will be needed, but up to date, we're not really sure how these will be. So just some things to keep in mind if you put people on variant-specific therapies. The very first days, you can expect an increase of secretions, so you need to anticipate to that. Increase your physiotherapy sessions the first days you start modulated therapy. We see an improvement in weight. in that way that we see that patients are getting obese. So there is another role for the dietitian. We need to pay attention on that. We want to keep our patients healthy. There is an improvement in respiratory symptoms, less exacerbations, but does that mean that we need to suppress all the other supportive therapy? We're not there yet. We don't have the right answer. And what about improvement in sweat chloride? What does that mean? That means that people with CF under modulators with a normal sweat chloride, they don't need additional salt when they do excessive exercise or when they have excessive sweating. It's important to keep in mind that these medications, these CFTR modulators, they give already a risk of hypertension. And if you add to that even more salt intake, and if these patients are obese, then we create a complete new pathology. Improvement of digestion. Most of the patients still need to take their carry-on, but there is a certain way of improved digestion, and we see in patients on CFTR modulator therapy that these fat-soluble vitamins can go up. So you need to be aware and you need to monitor them in the first phase of your treatment. And then we see more side effects that are less common in the CF community that we didn't have to deal with, like rashes, obesity, new psychological complications, side effects, and we need to be aware of drug-to-drug interactions. But I'm sure that Dr. Mieke Boom will highlight these more in detail. What else? Standards of care means also a multidisciplinary approach, but that will be for my next talk. So standards of care, what is it all about? It's about knowing the basis, knowing why we do things, and finding the good balance. It's a lesson not only for doctors, not only for healthcare providers, it's a lesson for life. Thank you.
Mulțumim frumos, thank you so much.
Moving on from Brașov, we have Dr. Dracea, Standards for CF Care in Romania.
Paving my way for the talk I had, which is a little bit difficult, but I try to underline the problems we have and how we go through these standards of care in Romania. I will switch to Romanian. Nu pot să nu încep.
I want to underline how important it was that when this disease was introduced in this magazine, The Science, in 1989. This is a very famous picture. You can see here Danny Bessette. Danny Bessette and his parents were and the community, the medical community, were very optimistic. They thought they would find quickly a cure. Unfortunately, it didn't happen, but we do have new and innovative therapies. This was a test in the blind at that moment, but it is important to see that since then we still have a lot to find out. My presentation starts with the European standards of CF care and the model that is mentioned in official documents. What the standards of care mean. The doctor speaking before me presented them very thoroughly. You know the constitution of a CF center, which is described in the standards of 2014. And the success of center-based care is proved because the quality of life improved considerably even before the modulators. The principles described in 2018 are still relevant today, and the patients need to have access to care and to the entire team. At this moment, the aspect and the evolution of the patients changed, and we might need to transition to another type of care, given that it is very obvious that there are benefits to the modulators. The COVID pandemic taught us that we can also take care even from a distance, and it was proved that we can do a follow-up even from a distance. Remote care is not advisable, but it is possible. We also need to have specialized doctors, psychologists, including psychologists, but clinical nurse, respiratory physiotherapist, physiologist, dietitian, social workers, microbiologist. Everyone should know about this disease. This is, of course, disease with a limited life expectancy, but the quality of life can be improved, and also it can be done through newborn screening, early diagnosis, and in adherence to treatment. You've all seen this graphic showing how the therapy is involved and what it meant when we speak about life expectancy. And all of this care can give all patients a timely care. We need to take into consideration their specificity and the specificity of the manifestations. Why do we need specialized centers in Romania? This is because it is a multisystemic disease, very complex, with a lot of risks, complications that we haven't expected, different phenotypes, and of course a lung disease that can lead to chronic infection, and we are facing a disease that still needs to be researched because we all hope for a cure. We have a new landscape where the patients, most of them have access to modulators therapy. The age of these patients increased, even in Romania. The life expectancy has increased, and luckily also the quality of life improved. Centralized therapies is a very centered care is very important, especially if we think about the accessibility, about funding and staffing. We need the necessary devices and equipment for lung treatment. Education is extremely important, and as I and other speakers mentioned, interdisciplinarity is essential. The structure of a multidisciplinary center is the one that you see on the slide. I will not insist upon it. Of course, these standards of care need to be established when we know the number of patients at European level with the necessary staffing, the services that need to be provided, the equipment, the clinical standards, the infection control policies. The same centers could provide care, but also trainings. What are our limitations in Romania? It is standard, it is clear in Romania that we don't have enough centers. Most of them are in pediatric hospitals, and they take care of patients from birth to 18 years old. The number of patients vary between 50, 75, but this is only the average. And one of the biggest limitations is the reduced number of nurses and physicians, and also a limited number of beds that are available for patients who sometimes need prolonged hospitalization. There is no proper infection control, and more often than not, we have difficulties in providing single rooms. How about the outpatient care? Unfortunately, we don't have space for controlling the infection, and it is difficult to provide a multidisciplinary approach for outpatients. Also, the imaging, CT, and other is covered, but we are understaffed regarding physiotherapists, dietitians, and who are specifically trained for CF. We need to focus on a newborn screening, but this also comes with challenges. Some of the patients come back to the hospital and they don't know that they were diagnosed and that they are positive. There are some samples that are lost, and we need to intervene. When we talk about the neonatal screening, the newborn screening, we also need to speak about genotyping. Late diagnosis in Romania is still a problem. We have children who are malnourished and or who have recurrent respiratory problems such as bronchiectasis and other pulmonary infections, and they are still not diagnosed.
We know what we need to do, we know what the standards are, but what we can do is slightly different. Nutrition-wise, for small children, for infants, we have special formulas for those who have malnutrition. We encourage breastfeeding. We monitor them on a regular basis, monthly. We try to offer education for a healthy diet. We still have problems with those children who have meconium ileus and who end up having surgery. Oftentimes there are complications in these cases. The existence of early modulators, even for very early and young ages, will for sure bring better outcomes for this age segment as well. Many families who come from poor socioeconomic backgrounds and have no education don't know how the treatment with enzymes need to be taken. The enzymes are paid for by the state, but they lacked in pharmacies. Adherence to enzyme therapy is problematic. All the families know how the therapy needs to be taken, but we still have malnutrition and digestive problems. We're still assessing this aspect, obviously, for each visit. Physiotherapy. Not everyone has a trained physiotherapist. We try to educate through leaflets, booklets, by explaining. If we have a physiotherapy vests, we train people how to use them. We monitor and we adapt the vest for each patient to get a maximum benefit. We adapt them for bigger children so that they can use devices at home. We encourage physical exercise, which is very important. And what usually lacks is the involvement of the family. Smoking, vaping, any other exposure to fumes. We need more support from society. Many families with poor backgrounds smoke. So their children are exposed to pollution, to traffic pollution, but also to smoke. About hospital admissions. This is done whenever it is needed, if assessed so by the clinician in cases of respiratory failures, GI failure or problems, for common medical problems if they're not managed by the GP. Exacerbations. They are usually admitted with antibiotics, with intravenous synergic active for PA antibiotics for 10 to 14 days, depending on the previous lung status. Some patients have a cap, so we always need to have a differential diagnosis and exclude other lung pathologies, such as chronic bronchitis or others. GI problems. These usually complicate the evolution of an infant and aggravate the nutritional status, especially of those who are malnourished. For those who don't use modulators, there's a risk of dehydration with salt loss. We still have a DIOS problem, which is sometimes taken for constipation, and it goes unrecognized, so that's a problem. We need the involvement of pediatric surgeons, and they should have more information about the disease. Hospital discharge, this usually takes place 10 days after the treatment. We reiterate all the chronic treatment plans, we explain, we try to educate, and we plan the following visit. That happens monthly when there are complications, or every 3 months when the patient is stable. We need to bear in mind that we need to take care of the families as well. We need more community support and more education. Luckily, each family gets reimbursement for treatment. We try to give written plans for nutrition, for PERT, for aerosol therapy. But we need funding for the aerosol and inhalation devices because parents don't usually afford this. Although each family gets funded for having a chronic disease, that's a handicap certificate. CFTR modulators, we have them, which is a great achievement. We're waiting for their approval for children of over 2 years, for Kaftrio. These children are assessed according to the national protocol. The patients that use modulators visit the hospital less, have fewer exacerbations, have a better lung function, have a better quality of life. How adherent are they to the treatment? Well, that's still to be seen. What is the future? The future means past needs, but also new needs as well. Perhaps we will get more access to remote assessment as well, which would be an added bonus to those people who already use modulators. The future would also mean to have a bigger team with a lot of expertise and knowledge, and to have accurate and proper facilities to offer quality assessment. Let us not forget that CF lung disease under modulators is still a problem. Patients that undergo therapy have a better lung function and fewer exacerbations, no longer produce sputum, and have fewer transplants. But we need to see what kind of biomarkers we use for these patients, how often we assess these patients, what the treatment for the stable patients will be, how we should monitor them, what the colonizations are in the case of patients that no longer have sputum and we cannot identify germs. We also need to take into account the fact that for the time being we don't have information about the impact of triple modulator therapy on the infection. So, we're facing a change in the future treatment of the disease when it comes to diagnosis and therapy. Perhaps algorithms offered by AI and machine learning will help us in future. Perhaps they will rely on clinical databases, particularly for imagery and in assessing genetic profiles. We know what the current situation is in most European countries and in the world. We have more adults with CF than children. We're facing a situation where the needs of care are shifting for these adult patients. They will get diabetes, they will probably have bone issues. There's a high risk of gastrointestinal cancer, particularly for the intestines. So these patients will have to be monitored regularly. So this will also change the standards of care. As said before me, the high-calorie diet and high-fatty diets that can lead to diabetes, coronary disease, and so on, will be our main concerns for the future. Building on what we know and what is recommended in the European standards of care, what is important is to maintain this information and knowledge about the disease, about the eligibility of patients for modulator therapy, to maintain and to keep our attention on those who are not eligible for innovating therapies. It's important to keep in contact with our lung specialists, with general physicians and all the specialists. And we should never forget that our patients will become adults one day and will have potentially more complications. In Romania, we haven't reached that stage yet, although every center in Romania already has children of over 18, and ever more so. We would like to have more members in the teams, to have better facilities in outpatient and in hospitals, to have adult centers, to have access to transplants in Romania, and last but not least, to have better education on cystic fibrosis. Thank you. Thank you, Dr. Laura Dracea. Moving on.
Management, slotul, you took a 5-minute break, a 25-minute break. Good luck, Elke.
Hello again. I didn't see it there. Okay. So my task is to give a summary on the multidisciplinary CF team management. And as said before, outcomes of people with CF cared for in specialist CF centers are better than those who are not, even before the era of new drugs, of the new CFTR modulators. So there was a framework, a standard of care paper describing the model of CF center in 2014. But there are adaptations and recommendations in a changing world where we have now access to modulators and we have been in a pandemic. So it was time to update a version of the standards of care on multidisciplinary approach. So what does this paper say? The multidisciplinary CF team should offer support to people with CF, where the CF patients and parents are central, and where, in the ideal world, the multidisciplinary CF center has a pediatric and an adult pulmonologist, CF clinical nurse, a social worker, a psychologist, a dietitian, a respiratory physiotherapist, an exercise physiologist, microbiologist, and a pharmacist. And this team has to give individualized care and easy access of care. This team has to sit together to discuss pre- and post-visits of patients and has to invest on quality management meetings to improve quality of the team, to improve quality of care. There is need for a continuous development of all the members of the multidisciplinary team by attending conferences, taking courses. So what are the tasks of the CF team in global? The CF team needs to network with associated specialties in the same hospital or in another hospital, enabling to get the expertise in all the different domains like genetics, radiology, internal medicine, but also the ENT doctor, psychiatry, intensive care unit, assisted fertility services, gynecology, because our patients are getting older and they have a child wish. There is networking needed with transplant centers, lung, liver, but also networking with primary care physicians who can help you by assisting with other non-CF related diseases, especially in the adults, by helping with disease prevention screening. The CF team needs to have links with national, international, other CF centers to share knowledge and to share and to discuss difficult patients. And it is important to have links with local or national patient representative organizations to find out what the needs are of people with CF. The multidisciplinary team needs to engage to participate in data collection, because it needs to inform patients about the importance of collecting data and the value of the CF registry. It is important as a CF team to discuss results from the CF registry that can help people with CF to better understand their disease and in a way then improve therapy adherence. The multidisciplinary team has to engage to participate in, so there is a role in education in the team, and it has an engagement to participate in clinical trials as well. Why? The team should inform patients about the possibility of participating in a trial, but even if that is not possible, even if the center is not actively involved in clinical trials, it is important to inform your patients about the value of research, to discuss results from the newest clinical trials with people of CF, to better understand their disease, to better understand how they should be best treated. So also here again, there is a role of education by the CF team. But we all know the ideal world is often far away from reality. So if we have a look at the UZ Brussels multidisciplinary team, if we need all these, I can assure you, and there is a bug, we do have an adult pulmonologist, but we don't have an exercise physiologist, for example. This is a task of our respiratory physiotherapist. We do have a microbiologist in our hospital, but this microbiologist is not a member of the multidisciplinary team. This member does not sit around the table every week discussing all of our patients. We can get information if we need so, but it's not a member for the team, not the ideal world, and the same for the pharmacy. By visiting Chilla here in Cluj, we found out that this was mainly the multidisciplinary team in Cluj. So the ideal world is often far away. Let's have a look at the way we work in UZ Brussels, because I think that was a bit meant the reason why I had to give this talk. We have different pediatricians with different specialities, the pulmonologist, the gastroenterologist, an endocrinologist, and an ENT doctor, and we have the same from internal medicine. We have a dedicated CF pediatric nurses and dedicated CF adult nurses, and then a social worker, psychologist, dietitian, and a physiotherapist who cover the adult and the children with CF. We have a lot of support from our secretaries who help with all the paperwork, all telephones, administration things. So what we do, we have a meeting all together with this team once a week on a Thursday at noon, where we discuss the patients that we saw and that will be coming in the outpatient clinic in the afternoon. And we always do that with the pediatrician and the adult physicians together, so that we as a pediatrician, we don't lose the link with our children who grow up, and we know now how they live their lives. And on the other hand, the adult physician knows more about the children, and they know which difficulties they had before they really enter into the adult service. There is a possibility of patients to reach us 20 hours in 20 hours. It doesn't mean that our secretaries are really living in our hospital, but we have a plan for that. And we see each patient every 3 months, and we do once a year an annual checkup. We have an issue these days. Our CF nurse, we had 2 pediatric CF nurses, and Tina is the youngest of them. She's member of the CF nursing working group, and she recently decided to say goodbye to CF. She will work in a hospital nearby. She's pregnant for a second child, and she was my second hand in the nasal potential difference measurements. So Tina has gone, and Chris, who is the second CF nurse, has experience for over 35 years in CF, and she will retire by next year. So we need to find a dedicated pediatric CF nurse. So I think every center has its pitfalls, and every center, there is always something that you can improve. What else about the situation in Belgium? So there are in Belgium 7 different reference centers for a very small country. We try to meet as doctors together to discuss patients, to discuss projects. It used to be in-person meetings, but since COVID, everything has changed, and now it's changed onto online meetings, and we get support from the patient association for that. We have a Belgian registry, and for those who have a remarkable eye, you may have seen that Belgium was in grey at the European registry. That is because we had some huge IT problems and we were not able to give this annual report every year. So sometimes we lack data, Belgian data, in the CF registry, in the European CF registry. How do we work? We have board meetings, and in the board there are, the members of the board are medical doctors from the different hospitals. We have once a year a scientific meeting, and once a year we have a benchmarking meeting where a certain item is highlighted and where we found out which center scores very high on a certain item, and they try to share with us their current practice, what they do to achieve this goal in order to optimize health, optimize care for every patient in Belgium in the different centers. So the registry is something that we use profoundly. And what else? In Belgium, we have 3 CF centers that are member of the clinical trial network. So if a patient who is followed in another center wants to participate in a clinical trial, they can be referred to one of these other 3 centers. So team members should have knowledge on CFTR modulators and eligibility and availability. That is something that has changed in the years. And team members must adapt to reflect to the improved life expectancy of people with CF. So that is something that is a dramatic change compared to, let's say, 5-10 years ago. And pandemic learned us something too. Pandemic learned us that we can do remote care. Remote care can assist early detection of clinical decline, and we can rapidly intervene. It can support therapy adherence. You can do that in a remote session. Different members at different times can be involved. It avoids long travel and difficulties of finding a parking place. It reduces financial burden. It reduces the risk of cross-infection. And even the next scale, the high level of remote care could be remote care where blood pressures can be used, home spirometry can be delivered. However, we need to be cautious to realize that this remote care should not replace all clinical reviews, but this gives us so much other important information. Regular sputum samples, for example, are really needed every 3 months. So remote care, yes, without changing quality of life. So in summary, if you go to the standard of care paper that nicely defines how an ideal multidisciplinary team should work, you can really read this table. I'm not going to summarize it again. But in summary, the CF team, what does it? The team supports people with CF and the family, educates people with CF and the family, and acts to their best ability, because as a team, you achieve more. So this is our team. Thank you very much.
Mulțumim frumos, profesor Dr. Elke de Wachter. Continuăm.
Thank you so much. And now I would like to give the floor to Cilo Eniko Sabo, our doctor who's at home here. You have the floor. Hello, I will speak in Romanian because I want to be faster. It is difficult to follow Elke because she mentioned a lot of the things I also wanted to present. She underlined the role of a multidisciplinary team, but I will re-emphasize that our purpose is to provide professional health care. I don't want to repeat the key members of a multidisciplinary team because you already heard about it, but I insist upon the importance of collaboration for a better for a better communication and a better collaboration. And we can do that by having regular meetings, by having a common access to the file of the patient. We have to have a shared approach focused on the patient. New tendencies, new trends want to involve the patient and the caregivers in this process of treatment. The benefits of the multidisciplinary approach are an improved patient outcome, comprehensive management of care, and the increase of the quality of life. This complex management wants to cover both medical and psychosocial needs, and of course we need to prevent complications. So early interventions in lung infections are recommended. And of course, we need to avoid nutritional deficiencies. There is an article quite recent mentioning that these are the members of a multidisciplinary team, but the latest article that I read about the structure of a CF care center in the US recommends, besides what we already know, also a complementary team, a technical team, helping the core team. So there's a group of specialists who are essential to caring for these patients. And it is important for them to provide regular consultations. What we have for the moment in Cluj-Napoca, we have pediatricians, we have a gastroenterologist, we have an infectious disease doctor, we have a psychologist, pharmacist, we have dietitians, which are not specifically trained, 2 cardiologists, a social worker, a diabetes and endocrinologist specialist, clinical genetician, rheumatologist, and hematologist. We also collaborate with otolaryngologist. We also have a general surgery radiologist, microbiologist. We also have intensive care physicians, a psychiatrist, and a nephrologist. We need in our center clinical nurse specialists, we need a physiotherapist, but we are very hopeful that we will include this in our team very soon. We also need more secretaries, coordinators for our database, and palliative care specialists. What are the challenges of a multidisciplinary team? Well, the main challenge is to coordinate between specialists, because we have limited resources and we should have better time management, because our teams are very occupied. Maybe remote medicine, telemedicine could be an idea. It could be part of the solution, especially for remote patients, clear communication protocols, and maybe also have ongoing training and team building. In conclusion, there's a critical role of the multidisciplinary team in improving the outcomes for CF patients. we also need to collaborate and to continue our collaboration for this disease, and also we need to have a continued development. This is part of the nurses who try to do their best to improve the quality of life of our patients. Thank you so much. Thank you, Dr. Cilo Sabo. And now I would like to give the floor again to Dr. Elke de Wachtker for another session.
Again, this will be my last talk today. Don't worry.
It's a good talk. Okay.
So this talk we will highlight on the doctor, the CF physician, the pediatric pulmonologist, the adult pulmonologist. So looking a little bit in depth to the Hippocratic Oath, the physician is the doctor. And we act according to our greatest ability and judgment and will do no harm or injustice to our patients. As a doctor, whatsoever we do, which houses we enter, we will abstain from all intentional wrongdoing and harm. And whatsoever we shall see or hear in the course of our profession, we will be holding these things to be holy secrets. But what the Hippocratic Oath doesn't state is that a physician is not a healer. And that's important to keep in mind. We don't always heal. What the role of the CF physician is as a doctor in the CF team is to act to their greatest ability and do no harm. And this is an ongoing process because we need, therefore, updated knowledge on the disease and its natural course, on therapeutic strategies, but also on their availabilities, on the possible side effects and drug-to-drug interaction, and to the needs of patients and families. And we need to have the ability to translate this information into a personalized, real-world situation. And what is needed for that for the physician? Education, 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 but also continuous training, training of specific skills, case discussions with colleagues, attendance of conference. But what a doctor also needs is common sense, dedication, empathy and humanity. And the doctor needs a team to be surrounded. So the role as a CF physician as a coordinator, let's say in the ideal world, this can be seen as a conductor, where the CF physician is surrounded by all people with a lot of expertise. And there the role of the physician as a coordinator is that patient and family are central, and that the doctor or the coordinator assembles expertise of these team members and organizes these weekly meetings to have patient discussions, to have an eye on quality improvement, and to have an eye on team spirit. The coordinator of the physician is a bit the coach of the CF team, but on the other hand, a good team makes that everybody cares for everybody. So the CF team coaches and supports the CF physician. What else? What else is a role of a CF physician? A CF physician is a networker. A networker in their own hospital, but also in the hospitals outside your own hospital, to improve expertise and care in a personalized manner. Is a networker with patients' organizations in order to improve access to care, to improve the needs of people with CF and their families, and to improve awareness. We were really lucky to have the support of the Patients Association for example, implementation in newborn screening in Belgium and the reimbursement of these highly costly CFTR modulators. But also as a networker with other CF communities to improve knowledge on standards of care, to improve knowledge on scientific developments, and to have insights in the needs of people with CF outside your own hospital and your own country. There is a role of the CF physician as a scientist. As a scientist, we need to engage with the patient registration, the patient's registry to improve national CF registry data, to educate team members on the role and the needs for the CF patient registries, and to guide team members in completing the annual CF registry, because that's not only the role of the doctor is in that way a good coordinator of the team members. Okay, sorry. As a scientist, I know not everybody can be involved in clinical trials, but at least it is important to try to be part of clinical trials because it opens your perspective, it improves care, it improves the development of new therapeutic strategies. And on the other hand, the CF physician often has some interest in a certain domain, and it gives you the possibility to gain expertise in a specific domain. So what is needed for all that? You need a team, you need teamwork, and you need money. And you need a healthy and a very safe environment. So as I said before, the ideal world may be far away from reality. As I told you, in our team, we have our issues, but at least the CF physician can act as a conductor, a coordinator. In the case of Cilla, she's her own coordinator, apart from nurses who support her. But the CF physician in Cluj, to my opinion, is rather a multitasker. So CM physicians, what are they, what do they? They handle to their best ability. They take care of people with CF and families. They take care of the CF team. But above all, we should not forget that CF physicians have to take care of themselves to have enough power and encouragement to move on. Thank you very much.
Thank you, Professor Dr. Elke de Wachter. Mergem mai departe.
Moving on, role of the CF nerve in the CF team. I will invite in the Roelants for this from Belgium. Thank you.
Hello, everybody. My name is Cindy Roelants. I am one of the 3 CF nurses in our CF center in Belgium, Leuven. I will first say what the theory has to say about it, what the ECFS standards of care say, what the role of the CF clinical nurse is. The CF clinical nurse specialist should deliver skilled support, advice, and care directly to the patient and family, wherever it is needed, both when attending hospital and at home. The role of the CF clinical nurse specialist should include education, advocacy, and psychosocial support, provision of support and education at home, particularly for home intravenous antibiotic therapy, nebulized therapy, enteral feeding, and non-invasive ventilation, provision of education to others about CF, acting as a link between the patient and family, primary care, community services, and hospital, acting as a resource for training and education of other professionals involved in the CF care. So that's the theory, but what do we do in practice? The CF nurse is actually a central point in the team. We work closely together with physicians, psychologists, social worker, physiotherapy, dietitian, and secretary. We have several roles, such as giving information, to give education. Follow-up is a very important part of our job, and tender loving care is there a big part in it, and organization as well. So we give a lot of information to our patients. We are the contact person between the patients and the parents and the multidisciplinary team. In many situations, we are the first contact that patients contact when they have any questions. And we refer them to other team members, such as the doctor, the dietitian, psychologist, physiotherapist, and social worker when it's needed. We inform the patients and parents about CF. What is CF? What does CF do to your body? We inform them about their therapy and inform them about new therapies that they have to do, information about nebulizers, hygiene, etc. We go to nursery and daycare to inform them about CF and the day-to-day CF care. We also go to schools to inform them, the teachers, what is CF and what they see in their classroom with CF. And we also informed the other students in the class. And we inform and train other nurses so that they become more experienced in taking care of other patients with CF. We also give a lot of education. We have a structured and repeated CF education plan as part of the multidisciplinary care. We give hygiene-related education. We support the patients with adherence to their therapies, for example, through better understanding of the treatments. And we take care of the nebulizing equipment, and we give a lot of education about the use and maintenance. So we have a look further in this. At the pediatrics, we have organized education moments. We have a structured plan, and we do that in several times during their life, at the age between 6 and 8 years old, at the age of 12 and 14 years old, and at the age of 16 to 17 years old. And we give that education during outpatient clinics and also during hospitalization admissions. And those education moments are provided by the pediatrician, the dietitian, the physiotherapist, and also the CF nurse. So as a CF nurse, at that education moments, we talk about between the age of 6 to 8 years old, what is cystic fibrosis? What is the function of my lungs? How can I prevent getting sick due to transmission of bacteria? What are bacteria? At the age of 12 to 14 years old, which medication do I use? Why do I need to take this medication? Because it's important to know why you have to take it to have the possibility to take it. And we have to give hygiene guidelines. And at the age of 16 to 17 years old, we go with them in discussion and give education about their therapy, medication, self-care, reproductive health, hygiene, and everything they want to know else about their disease. And we do that to prepare them gradually to become more independent in their CF care during their transition to adult care. We also give education in the adult care because it's not over when you go into transition. We're helping the adults with CF to maintain a balance between adherence to their treatment and their daily life and work. We give education, counseling, and support about reproductive health for both men and women with CF, and we give them pre- and postnatal care. A big part that is very important is also the preventive care of growing older with CF, such as cardiovascular risk, cancer, and bone health. And we give them for education about transplantation and end-of-life care. We give hygiene-related education, and a big part of that is infection prevention. So we have segregated consultation for people with different germs. We stimulate them to use a facial mask in the hospital. We tell them to keep a distance of at least 1.5 meters from other people with CF. We give them cough and sneeze hygiene. And we tell them to wash their hands before eating or therapy or when their hands are dirty. And in the hospital, it's important to use hand sanitizer. We tell them to avoid subtropical swimming pools because the combination of the hot water, the humid and hot ambient temperature, and the subtropical plants with pebbles and soil stimulates the bacterial growth, such as Pseudomonas aeruginosa. We give them education on the disadvantages of smoking because it's very bad for their health, not only active smoking, but also passive smoking. So we motivate and help the patients with CF and the children with CF to quit smoking. One of the most important hygiene measurements is the purification of the nebulized equipment to prevent infection. After every use, we give the advice to rinse all the materials under hot running water, to dry the material, and to store the material in a clean cloth. And once on a daily basis, we advise sterilization of all the material to prevent bacterial growth and fungus. Some of our patients can go home with IV treatment after a short hospital admission. So we also give education to go to home with the home IV treatment. We teach the patient and parents to dissolve and administer intravenous antibiotics. We make sure that they know everything about the sterility rules and that they also are respected. And we evaluate whether the patient or the parent knows the technique enough to be safely discharged at home with a home IV therapy. And we also takes care of the administration. There is also a need of following up the home IV treatment at home. We work together with a home care company who does the home visits for the lung function test, blood levels, catheter care, etc. And the CF nurse follow up on the home visits, the blood result, and the patient report. Home IV treatment is not for everyone. It's only in case of frequent needs of intravenous antibiotics. You have to have the right type of catheter, so it's not possible with the peripheral catheter. And it's only when you have the possibility to have good physiotherapy at home by the home physiotherapist. We also follow up a lot of our patients. We follow up after a new diagnosis, at least once a week after new diagnosis, and even more when it's necessary. We evaluate newly started therapies. We contact the patients and parents at home to evaluate their health status after a health issue, to know if the therapy has a desired effect or does something has to be adjusted. And we do that by phone or emailing them. And we give a lot of emotional support. So the CF specialist nurse makes an essential support for the physician at that part. Another role of us is organization. We're preparing the CF consultation, including investigations, multidisciplinary follow-up, medication, and education. We plan hospital admissions. We plan the home IV treatment, and we're planning pre-transplant investigations. We work with patients, and this was only in theory and in practice, but because we work with patients every day, I also found it very important that they have a say in all of this. So I asked several of our patients what they thought was the role of the CF nurse in the team. I will not read everything about it, but I will have some highlights and be their voice today for you. First, we have Evelyn. She's the mother of Louis, who is 8 months of age. And she says, for us, the CF nurse is indispensable in the team. Otherwise, the doctor would be overwhelmed with all kinds of questions that could also be answered by the nurse. Melissa is the mother of Nifeli, and Nifeli is 19 months old. And she said to me, the CF nurse is a trusted contact person who is very knowledgeable about various issues, who makes sure that my questions are always answered, who follows up the situation with me. Florine is a girl with CF from 20 years of age, and she said, for me, the CF nurses are really a point of contact. Whatever question I have, I can always contact one of them by mail or phone. Xander, a boy of 18 years old with CF, he says, it is someone who provides information and CF-related issues during consultations, both to parents and children. It is someone with a great willingness to listen and attention to the needs of parents and children. Annelies is the mother of Vince. He's 5 years old. He has CF and a lot of other health issues. And she says, if there were no CF nurse on the team, I wouldn't really know what to do when I'm stuck with something and end up with a lot of frustration about my child's medical condition. Ellen is the mother of Aiden, and he's 18 months of age. You see that I work mostly with the children in our hospital. And she says, you are always our first point of contact for any questions, no matter how big or small. In most cases, you offer a solution immediately, or after brief consultation with the doctor, a treatment is rolled out, and we can get started. You are the link between patients and the doctor, a very important one. Thanks to your medical expertise and strong communication skills, we have been able to make even the smallest inconveniences comfortable for Aiden. And I'm not only working with patients, I also work in a team. So Professor Boon also told me what she thought was the role of a CF nurse. And she says, as a pediatric pulmonologist working with children with CF, I am very grateful for all help we receive from our CF nurse. She has a very good understanding of all technical aspects of CF management and coordinates the care. On top of that, she builds strong relationships with patients and their parents and communicates very effectively in a compassionate way. She knows how to bring messages from the doctors to the patients and how to empower patients in their daily life with CF. Cindy is not only a nurse, but a crucial partner in our multidisciplinary team. I like to end my talk to say that it's a really big honor to work with CF patients and their parents every day. It's not only a job, it's a mission. Thank you very much.
Thank you so much, Cindy. Ne pregătim să încheiem acest panel și următorul invitat care va vorbi despre Learning Package Education.
The last presentation of today comes from Chris Smith from Brighton, UK.
Well, good morning, everybody. So I wanted to start by thanking the organisers for inviting me to speak today. My name's Chris, and in combination with my colleague, Dr. Helen Chadwick, we help to support, coordinate and run the European Society's education project. And how this project can help you and your education is the topic of my discussion today. And I've got three key messages for you. The first message is that we recognise the challenges that we all face in keeping up to date with our education and knowledge in the area of cystic fibrosis. And I want to explore some of those barriers that we all face. The second key message I've got for you is that the education project is here to help you. And I want to explain what the project is, what it offers, and how it can help you in your practice. And the third key message I've got for you is that we recognise that everybody has different priorities for their own education and for the education of their teams. But I want to show you what we're doing to help achieve the priorities of those here in Romania. So I want to start with my first key message, all the challenges and barriers we face in staying up to date. And I can illustrate this for you very nicely by showing you this. If you were to type the phrase cystic fibrosis into one of the large medical databases, you can observe the number of publications that happen year on year. And what you can see is that every year since the 1960s, more and more papers have been published in the area of cystic fibrosis. And for example, in 2023, nearly 3,000 pieces of literature were written. This is a lot of research and a lot of reading. And it's not only the sheer quantity of literature that's increased, it's the diversity within it as well. And this can be illustrated in a different way. If you look at one of the most world-famous textbooks in cystic fibrosis, the Hudson-Guinness, you can see that one of the early publications from 2007 had around 400 pages. Now, the latest edition of this textbook, published this year, now has nearly 750. And this illustrates the emergence and the diversity of many new areas within cystic fibrosis. So clearly, one of the main barriers we all face is the sheer quantity of literature in around our topic. But this is not the only barrier. We also know the barrier of time. And this was mentioned very nicely by Dr. Maria from Bucharest in her talk yesterday. And she recognized that time was a barrier for her and her team to optimize care. We also know there's the barrier, of course, of cost. Attending conferences is a fantastic way of increasing our education. But the financial burden of these and the burden of cost to time away from our centres and our families is huge. And finally, the barrier of language. I know that if I have to read a guideline in French, it is going to take me a lot more time and a lot more effort than if it was written in English. So these are barriers that we all face in staying up to date with the most recent advances in CF. But what I want to show you is that the ECFS Education Project is here to support you and address many of those barriers. Now, the Education Project was set up in 2016, and central to this project has been the development of the Education Platform. Now, the Education Platform is a web page that houses a vast array of resources, data, and information to support you and your team's education. Now, to access the Education Platform, you simply log on through the ECFS website. You select Education in the tab, and it takes you to here, your individualized education webpage. And from here, you have access to all the resources that we have available. And we have free and open access to all members of the twinning sites, as well as all members of the ECFS. And I want to illustrate for you a few things that are included on the Education Platform. We have the e-learning project. This project has been going for the last few years, and there are 2 parts on the platform currently. And each part is made up of between 6 to 16 education modules delivered by leading experts in cystic fibrosis across Europe, covering multiple attitudes and instances of physiotherapy, exacerbation management, psychotherapy. And on the platform, we have all of these available to watch, and these are all categorized in a catalogue that you can see here. So it's clear what will be covered in each of the education programs and what objectives will be met. We also have on the education platform the syllabuses. Now, in the last few years, each of the members of the CFMDT team have been developing a syllabus. And these syllabus help define the key roles and the key knowledge required for these specialists to deliver the best care. So, for example, this is the syllabus for a cystic fibrosis nurse specialist. And it clearly defines the roles, and it clearly defines the knowledge that will be required. And these will be very helpful in the development of new roles in situations such as yourselves, to help ensure that those who take on the responsibilities know where the gaps in education are, so these can be filled with the platform. We also have conference recordings on the platform. Now, for the last few years, we've been recording pre-conference courses, we've been recording symposiums, we've been recording satellite sessions, and these are all available on the platform to watch. And we have recordings from Vienna, from the conference in Rotterdam, and from the conference in Glasgow. So if you didn't make it there, you just have to make it here, to the platform, where you can see all of them as if you were there. We also run webinars on a regular basis, and these are open access to all members of the CF community. And these cover a variety of different aspects of care as well. And I would recommend you all next week to possibly join the webinar on the standards of care, which will be being beamed live in the middle of next week. And you can register for that on the ECFS website. We also have been including conference material from other conferences. For example, in December last year, a joint ERS conference with the ECFS was held in Milan. And this was a showcase of management of future care of adults with cystic fibrosis and future perspectives. But if you didn't make it then, you can watch it now on the platform whenever and wherever you are. And finally, we've got downloadable data. So, for example, all of the standards of care and many of the individual guidelines are all available in one place, all ready to download for you. And also, we now have downloads for all the posters and all the abstracts from the conferences. So no longer does not attending the conference preclude you from access to the most recent data and the emerging studies. So hopefully you can see there is a range and diversity of education materials available on the platform. But there's other developments too. So with the help of Pavel and Helen and Claire and Hilda, we've been developing work for the Twinning Project, which has invested money in education translation equipment. So we now have education materials translated in multiple languages, including Romanian, Armenian, Latvian, Turkish, to bring and remove that barrier of language away. We also have a medication app, which has been developed in the UK by Professor Peckham, and this is available open access across Apple. And this medication app lists many of the medications that are commonly used in CF in alphabetical order, and it provides recommendations and suggestions and advice for doses for both pediatric and adult situations. So hopefully you can see that the education platform is there to support, as much as we can, many of the barriers that you face. But the third key message I've got for you is that we recognise that many of us have different priorities. Now, at the end of last year, we ran one of the largest international surveys on education within the ECFS and CF multidisciplinary team. And we received feedback from over 550 members of the team from nearly 60 countries. And we learned some very important lessons. For example, we learned that 7 out of 10 of our members use online education platforms to support their learning. And we also learned that the ECFS education platform is a commonly visited and a reliable source of information for education. But we also learned that every country has different priorities, and even within countries, different teams have different priorities. So, for example, we looked at the education priorities for Romania, and these were from the answers that were received from those who contributed to this survey. And we understood that the priorities from here in Romania is more variety of topics for education, easier access, downloadable content, and multilingual content. And what I'm pleased to tell you is that we have listened to your priorities, and what we have for you all today are memory sticks. And we have a memory stick for each and every one of you that's available at the back. And on these memory sticks are, hopefully, the answers to your priorities. Because each of these memory sticks contains 6 education packages, education lectures, that cover a variety of topics that are fully downloadable and fully accessible. No password, no login, just the education. And it's all been translated into Romanian with the help of Oana and many of the Romanian experts that we have here today. So we hope this represents a small step towards the society and the commitment to support your education and make progress. So my final 3 key messages for you again. We recognise the challenge that we all face in staying up to date with the most recent guidelines, development and progress within CF, and those barriers of cost and time and language. And hopefully I've been able to show you that the education project is hoping to address many of those barriers by producing more education that's more accessible, more available, and more understandable than ever before. And hopefully I've been able to show you that we understand your priorities and we are committed to supporting you in the future, not just with this now, but with further education. Thank you very much.
Thank you, Chris Smith. Mulțumim frumos tuturor. Pentru că am intrat un pic în timpul de prânz.
Please allow me to ask our guests here on stage if they have any feedback or anything they would like to add. And after that, I think we'll go for lunch. And we'll have the Q&A session during lunch or afterwards. We also have guests who need to catch a plane. Would you like to add something to what has been said?
The email address. Pentru a lui Chris. Chris, your email address.
Myself and Helen, my colleague, we will be at the back of the room. There's a poster with ECFS education. please do come and visit us. And of course, we're happy to share our email addresses and to share some of the education access that we've got. So please do just come and visit us at the end, or come and find me in the break. And of course, we're happy to share it.
Thank you, Chris. Mulțumim. Găsiți adresa lui Chris exact unde v-a zis.
Chris's email where he's at. So, if there are no further comments or no further feedback, we'll skip the Q&A session, or you can approach them a bit later for that. So we'll go off to lunch now. Bon appétit, and see you afterwards. Well, now we'll give you the certificate. Sorry, I almost forgot about that. It's just Chris is left without one. Okay, please.
And also Cindy Rulens. Mulțumim, thank you so much. Take your time, no hurry, no hurry. Thank you. Mulțumim frumos! Avem doar 40 de minute pentru prânz. Vă rog să vă grăbiți și ne revedem aici puțin mai târziu. Mulțumesc tuturor, poftă bună!